medical management. However, normal sclera and conjunctival anatomy is essential for the completion of the surgical steps and its favorable outcome. But in certain clinical scenarios, such as previous surgery, ocular trauma, or congenital abnormality, can render this tissue unsuitable for surgery and necessitating the alternative approaches. Coming into my case presentation, a 40-year-old male from Jagatsinghpur, Odisha, with a known case of juvenile open-angle glaucoma. His IOP was uncontrolled despite of being on maximal medical therapy. He has developed a progressive loss of vision during the 6 months due to development of cataract in his only seeing right eye. The left eye was phthysical following a traumatic injury in his early adulthood. His right eye showed a visual acuity of counting finger close to face, and the IOP was 20 mmHg on 4 anti-glaucoma medication. And there was nuclear sclerosis grade 3 in his right eye, and on fundus there was near total glaucomatous optic atrophy. Given this situation, we planned for a combined procedure of phacoemulsification with IOL implantation and trabeculectomy. So, as it is a routine procedure, why was this case so unique? In this case, we faced a significant challenges due to the patient's unique anatomy. Typically, the trabeculectomy is performed in the superior-nasal or the superior-temporal quadrant because of the easy accessibility and lower complication. However, for this patient, these usual options were not possible due to gross scleral thinning in the superior-temporal area, superior-nasal area, inferior-temporal area. The only area with a healthy viable tissue was the infero-nasal quadrant. Adding to this, there was abnormal pigmentation of the trabecular meshwork, which ruled out any mixed surgery. Also, tube shunt surgery was not possible because of gross scleral thinning. So we were faced with a question, where do we go from here? So the only promising area was the infero-nasal quadrant, but the operating in this quadrant brings a lot of challenges like limited working space, restricted visualization due to the proximity of the nose, and the awkward angles for the surgeon. So the situation was critical as his only remaining functional eye was at significant risk. So we have to go for an unconventional approach, and that's what we did with the infero-nasal trabeculectomy. When you have nowhere to go, you create a new way. So proper positioning was critical to ensure that surgeon had a clear view and access to the surgical site. In this case, the surgeon sat on the left side of the patient to operate on the right eye for the infero-nasal trabeculectomy. This is a short video showing a infero-nasal trabeculectomy performed on this case. So a partial thickness scleral flap is made in the infero-nasal quadrant. During the flap, this section, a premature entry occurs, which is very common in thin sclera. The routine phacoemulsification steps were carried out, and then the intraocular lens was implanted in the bag. The scleral flap, a pre-placed suture was placed, and there was prolapse of iris, iridectomy was done, and then sclerostomy ostium was performed. The scleral flap was then placed, and the tightness of the suture can be modified by tightening the aqueous egress by injecting the fluid from the paracentesis port. To prevent the post-operative hypotony, a releasable suture was given with 10-0 nylon. And the conjunctiva was closed with 2 wing and 1 mattress suture by 8-0 vicryl suture. So the 2 wings were at 2 o'clock position and a 5 o'clock position. So this surgery was technically challenging because surgeon has an awkward position and there was limited working space. The difficulty in maneuvering instruments are very difficult. So post-operatively, the patient was started on topical antibiotic, steroid, and mydriatic. So slit lamp picture of 1 week post-op shows a clear cornea with elevated bleb in infero-nasal area with a releasable suture. At 1 month post-op, the releasable suture was removed and it shows a diffuse bleb. At the end of the 3 months, patient's vision was 2160 with IOP of 12 mmHg with a good bleb, and gonioscopy shows a surgical PI which was patent. So in
Okay, Pallavi, probably you did not rehearse for 5 minutes. it shot little more. But anyway, it's a good, the surgery was excellent. Whoever did the surgery did a fantastic job. Your presentation, in one line you said, you give a releasable suture to decrease hypotony. So that is a wrong statement. You do not give releasable sutures for hypotony. It is to prevent raised IOP, where you can release the suture so that IOP can come down. Okay. Second point is, when you see a case of a diffuse scleritis, is it a good idea to cut the sclera?
We don't have
And,
any, sir.
and if you're doing a trabeculectomy, that means you are cutting the sclera. So if you did that, what precautions did you take to find out that it will not reactivate the scleritis? And if you would not have decided to do a trabeculectomy, what other options you had to control the IOP?
Already the patient was on maximal medical therapy.
Correct.
And there was abnormal pigmentation of trabecular measure, so we cannot do the mixed surgery. And only the inferonasal area where there was no thinning, so we cannot do any AGV surgery also. So we have to see the risk and benefit ratio. So we don't have any other option left, only this inferonasal quadrant trabeculectomy. And the patient was with us since 4 years, and it was a non-necrotizing scleritis. There was no reactivation.
Okay. No, so first of all, you can do a AGV in the inferonasal quadrant. There is nothing which cannot be done. And since you are putting a AGV or any sort of a valve, even if it's a necrotizing scleritis or a non-necrotizing scleritis, you can still put it behind without cutting any sclera. You can put a scleral patch graft over it, so that's okay. It can be done. What I wanted to know is that, did you investigate regarding activity? Why was what is the levels of blood markers?
It was done, sir. It was all
done.
negative only.
He has raised a very valid point that it is a necrotizing scleritis, healed necrotizing scleritis, where whenever you have a surgical intervention, always there is a worsening, and you have no other place other than this quadrant. It is good decision to take that quadrant. But did you do any additional immunosuppression so that there will not be any reactivation or worsening of this current situation? It can go into phthisis if it is not taken care.
No, sir.
That's what he's asking probably, but I know that it need to be immunosuppressed before you intervene for surgical this thing. See, you can do exotic things, but you need to be very, very careful.
Okay, sir.
So, C is the last speaker. With this, we
Thank you.
conclude this session.
Yeah, one speaker is not there.
No, sir.
Unka phone number hai?
No, C is presenting in PG session actually. C is a PG,
We'll
third year
wait.
resident. So,
We'll
C is
wait.
presenting RC Mayor session.
Next session.
No, no,
Yeah,
RC Mayor.
no. Ask her to come and then go.
No, no, sir. That topic, no. C didn't present. Because
Then
that was
she should not
glaucoma. So, C switched to that PG session. Okay.
No problem.
No, no. C is also not there. They three only. Okay.
Unka kya ho gaya?
Kiska, sir?
What happened to that other girl?
That is, that the same issue is there.
Same issue. Means
they don't
same
want to
topic they presented in both
They
overlap. So one will get the prize
Yes, sir. Okay, I
out
will.
of 3. Yeah. Okay, we have 10 minutes.
So, sir, I will request you to hand over the memento to our judges. Yeah. Yeah.
That is very, very essential. To stop at timer is very, very essential. Otherwise, I will do hala. Okay. These 2 things should follow. Okay, we will do that. Anyhow, 10 minutes are there, so we do the hala.
It's okay, ma'am.
Tikke, excuse me.
Sir,
ଶୁଣ ଶୁଣ ଆଚ୍ଛା ଏଥିରେ
picture. ଏପଟେ ପଳେଇ ଆସନ୍ତୁ। Thank you, sir. Now I will request Mohanty sir to come on the stage, please.
अरे आप वो देना दोनों दोनों साथ में था.
Thank you. Now I will request Rita ma'am to come on the stage, please. Thank you, ma'am.
अच्छा अच्छा मुझे मालूम पड़ गया. So this also we can take the photograph.
Over to Dr. Omega Priyadarshini for the next session on oculoplasty free paper.
Hello, good morning all. Now we shall move on to our next session. Dr. Bimal Kanta Tripathi, Oculoplasty Free Paper Award. We are lucky to have sir with us for this session. I am the moderator for the session, Dr. Omega Priyadarshini. I extend my warm welcome to our judges, Dr. Bimal Kanta Tripathi, Dr. Puspa Kumari, and Dr. Sabyasachi Patnaik. Unfortunately, only one speaker is there. Actually, I just came to know now only. Nobody is there, only one speaker is there, Dr. Bigyan Panda. Okay, Bigyan, start.
So So good morning everyone. I am Dr. Bigya Panda from AIMS Bhubaneswar, and I am going to present my work on the utility of a modified large diameter intubation during external DCR for distal canalicular obstructions. So a quick refresh into the anatomy of the canalicular obstruction. So distal canalicular obstruction refers to any occlusion beyond 8 to 10 millimeters from the punctum. So the causes of acquired canalicular obstruction can be due to mucocutaneous inflammation, drugs, or trauma, but the most common cause is the idiopathic one. Managing canalicular obstruction is challenging. The surgical treatment depends on the site and the degree of obstruction. Many modalities of treatment such as punctoplasty, retrograde intubation DCR, canalicular trephination with external or endonasal DCR, etc. have been tried with success rate varying from 50 to 90%. But the most feasible surgery in our setup is the canalicular trephination with external DCR and has been reported with a success rate of around 73%. So on searching the literature in a quest to increase our success rate, what we found was quite amazing. There is a mention of use of a large diameter intubation tube with a diameter of 0.94 millimeters used by different authors from Korea and the US, which is bigger than the routine tubes which we use in India with a diameter of 0.64 millimeters. The logic behind this is that a wider diameter stent keeps the canalicular channel walls more separated, thereby increasing the success rate. So necessity is the mother of invention. We found that the silicone sling, which we use to perform the tarsofrontal sling in ptosis surgery, has a diameter of 0.92 millimeters, which could be utilized as a large diameter tube. So we started recruiting patients with chronic dacrocystitis in whom the probing revealed distal or common canalicular obstruction, and we planned for external DCR with this modified intubation technique. The study was done in the Department of Ophthalmology, AIMS Bhubaneswar, from September 2023 to April 2024 with a follow-up period of 6 months. We excluded patients with proximal canalicular obstruction, functional anally obstruction. The surgical steps start with canalicular trephination with the help of a sizzler trephine till the obstruction is overcome, and a 2-0 Bowman's lacrimal probe can be passed freely. Then the routine steps of external DCR are performed till the creation of the lacrimal sac and the nasal mucosal flaps. The punctum needs to be dilated fully, and the tip of the silicone tube is fashioned so as to allow easy entry. So this is a short video. Okay, it's not working. So the punctum are dilated fully. The probe is inserted. So this is the tarsofrontal sling which we use in ptosis surgery. The tip has been beveled for the easy entry. It is entered into the lower punctum first, taken out through the osteotomy site. The other side of the tip is also beveled. And it comes out through the osteotomy site. So the tube is tied to the nasal pack which is already inside there, and it is taken out through the nostril. So this tube is fixed with the silicone sleeve which is already available with the tarsofrontal sling which we do, and it is secured within the sleeve there, and it is left inside the nostril. So the post-operative care is similar to that of the external DCR, and the tube removal is done after 6 weeks. So our patients were followed up at 2 weeks, 6 weeks, 3 months, and 6 months. The results of our study were that the mean intubation time was 9.1 minutes, which is a little longer than the conventional method because the tip is not a metallic one and is slippery. So it takes more time, but with practice, it is easy to perform. There were no complications at follow-up period of 6 months. There was significant difference between the pre-op mean tear film height and the post-op tear film height. The anatomical and the functional success were also 100%. This is the ASOCT picture showing the pre and post-surgery tear film height, where at the end of 4 weeks only, the tear film height has returned back to the normal height. So this is a wide internal ostium after 3 months post-surgery. The limitations of our study were we had a small sample size, we need a longer follow-up, more than 1 year, and there is a lack of objective comparison between the conventional intubation method and this modified technique. So to conclude, this modified large diameter intubation is an
Judges, any questions for her?
So this can be done.
Hello. I am asking you about endonasal dacryocyster rhinostomy.
Yes, sir. So this is done with the external DCR route. So it
Huh?
can be used in endonasal also.
No,
Yes, sir, it is done.
it done through the nose.
Yes, sir.
How it is done?
So we can do the DCR through the nose, and then we can put the tube from the punctum
No,
side.
no tube is necessary. In endonasal dacryocyster rhinostomy, no tube is necessary.
No, sir, tube is given.
Why? We have seen it not, method is not like that.
So there are different opinions about whether to use the intubation tube or not.
This
But
is one.
There are reports. There
Second
is
one is-
literature, sir.
Second one is, the hole which you are making, it should be as big as possible. Not a small hole.
Presence of stricture, so we have to depend what are the types of the stricture. Then how do you negotiate it by without any metallic tip? So it is a difficult
Initially
job.
we did the canalicular trephination with the trephine. So we have overcome the distal canalicular obstruction. We have
Oh.
not taken the proximal and the mid.
Acha, acha.
We have only taken those cases which are distal ones.
And then how
So it
you
is
do?
more than
How
10
do you define proximal and distal?
Yeah,
Any
proximal
criteria?
is defined that within 3 millimeter from
Yeah.
the punctum, and more than that or beyond 8 millimeters is the distal obstruction.
Thank you, thank you.
Actually,
how-
in endonasal dacryocyster rhinostomy, no incision is being given. Under the laptop, you see the probe
So I
is
have
going,
performed endonasal DCR.
but you have not described. Okay.
No, what is the long term? You probably you need to extend your study for next 1 year or so that you will get the more results.
Yes, sir,
And
we
it
are
is the
already
difference
doing
of 0.6 and 0.9, 0.3 millimeter diameter extra. Will that work or not? We need to see, because it depends on the primary pathology whether it
Yes,
is
sir. We
really
actually
persistent
need
or
to
not.
Measure the internal osteal diameter with the help of a nasal endoscope. whether
Yeah,
it is
yeah. It
actually
requires a
bigger.
prospective, a little bit more extended study.
Actually, all the
It's a
limitations,
good idea.
all the limitations that you have described
Yeah,
are
yeah.
contradicting your result.
No, that we are following up. We are doing a prospective study. for
Yeah,
that.
you can
We are
speak
No,
to
no,
the
three things you told as limitation.
Vicky.
One is the
You
smaller
can
size.
use the microphone actually, right?
Second
Yes.
is the difference between conventional tube and your
Yeah.
procedure.
It's
And
good.
So we are already doing that prospective study. We are
Yeah.
measuring the
Yes.
internal
Ah,
osteal
so that-
diameter.
So that will be more effective in establishing your conclusion.
It's a
rather than-
preliminary presentation, that
rather
is
than
okay.
present.
That
So-
is okay. No, idea is
So
very
this
good.
was to just implement
Yeah,
our thought process. We can also use this large diameter ones because the large diameter ones are not available in India. So there were literature about those large diameter from outside India.
But
So we
can
tried,
you leave the
whether-
tube for even longer time?
It doesn't require, sir, actually.
No,
It can
how
create
can
more
you, how
complications.
can you say, see, unless the long follow-up is there, if the no strictures are again
No, sir,
forming, then you can
whatever-
say it is sufficient.
Whatever the route is created, that is within 6 weeks only. So after that, the fibrosis is very less. So
No, but
still,
what is the outcome with smaller tube, smaller diameter tube? Is there any complications of
The
Comparative
success rate are less.
comparative group?
No, comparative group.
Is there any study of any complications or problems?
Yes,
of
there are
using?
literature, sir. There are
you
literature.
should have-
We are actually doing a
That you
thesis
should
on
have shown
that.
here also. These are the problems with the smaller diameter tube. So we
I think next year you will present a better
Yeah,
data.
that's a thesis going on
I
with
know.
my
That is correct.
postgraduate student. We are doing that.
With the how to
No, tell her to,
spend the time in this
tell her to
half
include
an hour
these
is
things also.
15 minutes before time.
Yes, sir.
Yeah,
So
comparison
the
with
full
the
protocol thesis is being performed, sir.
Yeah, I know. No, it's a good idea. Actually, idea is good. It is economical. Okay, you need not buy something else.
Yes.
But good comparative, a little bit longer term. You say 6 weeks is sufficient, but you follow up
No,
for
my
4 to 6
follow-up is
months.
6 months.
6 months, yeah, that
Yes,
should
sir.
be good.
So that
No, but adequate numbers with a comparative
the
group.
comparison group we
Yeah,
are
we
doing
need to
now.
keep. Yeah,
Next year
100%.
probably I will be presenting
Yeah,
my
yeah.
And
comparative
when to
data.
remove
Sure,
the tube?
sure.
When to remove the
So
tube?
6 weeks.
After 6 weeks.
No, that 6 weeks is sufficient or not, results will tell us. And depending upon the
So if we
failure.
don't remove those, then complications
One more
like
presenter is
granuloma
there.
and
Good,
all
good.
can happen.
Garland him.
So silicone material is available. Other than that, polypropylene tubes are available, but not in India. No, those are not available in India, sir.
Yeah, it's okay. If it functions well, then also it is indigenous and very cheap, economical.
Yes, sir. Yeah,
So,
sir.
yeah, the second presentation. Did you garland him?
Thank you so much.
Sir, session you should be on time, sir. Please. Okay, you start your presentation. Huh? Your name is not there? Hey now. No problem. Start your presentation. First slide.
Now our second participant is Dr. Mahesh Sahu. He will discuss about a case of leukoplakic OSSN.
Yeah, someone please help him. Dr. Sonali Singh. Anyone else? Gajal is means whole hall management she is doing, I think. आपका कुछ presentation है क्या इधर? है? Gajal, you have a presentation it seems here. Oh, really? Another Gajal probably. There are 2 Gajal Patnaiks. Yeah, your name is there.
Is there any other Gajal?
Gajal 2. टॉपिक ऑक्लोप्लास्टी में फ्री पेपर है बिमल कांत त्रिपाठी। ना अभी इनके बाद इधर कर दो, इसके बाद वीवीएम में कर दो, कोई बात नहीं। यू हैव द प्रेजेंटेशन? हाँ, देन कर लो। बिकॉज यू नीड टू बी देयर। No, you need not correct now. It's okay. Go ahead. You are with presentation. Start, I think. Timer भी start कर लो.
Good morning everyone. Today I am going to present a case of leukoplakic OSSN. A 50-year-old Hindu female resident of Houston, Odisha come to ophthalmology OPD with chief complaint of growth on left eye since 3 years. The patient was apparently alright 3 years back to start with. He complaining of reddish white growth in the left eye in the bulbar conjunctiva nasali, which was insidious in onset and gradually in progressive. and extend up to the cornea and approximate size of 11 into 11 into 4 mm in size. So irregular in surface and ill-defined margin associated with diminution vision, watering and discharge, not associated with diplopia and any other lymphadenopathy. So coming to past illness, no history of trauma to right eye, no history of any ionizing or arsenic exposure, not a known case of diabetes mellitus, hypertension, HIV or any other chronic illnesses, no past surgical history or organ transplantation present. Family history nothing suggestive, personal history a mixed Indian diet with average body build and normal bowel and bladder habit present with no addiction, general examination within normal limits, and systemic examination also in normal limits. Coming to the ocular examination of the right eye, the patient was right eye, all the findings are within normal limits with visual acuity 6/36 due to presence of immature cataract which is NS nuclear sclerosis grade 2. Coming to the left eye, the lids and adnexa in decreased interpalpebral fissure height. In conjunctiva, there will be reddish white mass of size 11 into 11 into 4 mm in the bulbar conjunctiva nasally, extending up to the cornea, ill-defined margin and irregular surface. And all other findings are within normal limits. And visual acuity is counting finger 3 meters. Coming to the extraocular muscle moment. Video is. Yes. Extraocular movement is full, free and painless in all gaze. Coming to the diagnostic tools, impression cytology, in vivo infocal microscopy and high resolution OCT and fluorescent and stain and rose bengal stain was done. In impression cytology, there will be moderate dysplasia of squamous cell was present. Coming to the summary, a 50-year-old Hindu female presented with growth in the left eye since 3 years, which was reddish white in color nasally in the bulbar conjunctiva, insidious in nature, gradually progressive to attain the recent site, extending up to the cornea, which irregular surface, ill-defined margin, non-pigmented associated diminution of vision, watering and discharge. On examination, VA was 636 on right eye and counting finger 3 meter on the left eye. On slit line examination, decreased interpalpebral fissure in the left eye with reddish white mass in the bulbar conjunctiva, nasally extending up to the cornea with irregular surface, ill-defined margin with leukoplakic, not freely mobile, non-pigmented. On impression cytology, moderate dysplasia of squamous cell are seen. So my provisional diagnosis was left eye non-pigmented leukoplastic OSSN with senile immature cataract, nuclear sclerosis grade 2 plus cortical cataract, and right eye senile immature cataract, nuclear sclerosis grade 3 with PSC grade 1. Coming to the investigation, within all the investigation within normal limits with NCCT orbit also within normal limits. Coming to the intraoperative surgery, video is after the surgery, the patient was given with reconstitution of mitomycin C, which was 0.04% of mitomycin C 4 times a day as eye drop for 2 weeks and 2 weeks off period for 3 cycles. And these are the post-operative picture of day 1 and day 7. And the histopathology findings show the grade to moderately differentiated OSSN. Final diagnosis is left eye OSSN grade 2 moderately differentiated with senile immature cataract on the left eye and right eye senile immature cataract. So my take home message, don't miss the lesion. These lesions mimic like pterygium with feeder vessel, and OSSN in young patients will be should be
questions. Now, when you see the lesion, surface lesion, it's very, very typical of OSSN. Though I am a retina specialist, I have seen a lot of OSSN. So it's very typical. Why do you think that it will be confused for the pterygium?
in any inflammatory lesions will be
No, inflammatory lesion and this is totally different.
Yes,
This
sir.
is a.
But in
yeah.
some cases, in OSSN, it's mimic like pterygium also. In this case, it
Yeah.
will clearly seen, sir.
Second is why mitomycin C is used. 5FU can also be used, no, which is much more surface friendly.
In our setup, sir, mitomycin C is only available.
Acha, for glaucoma and as well as oculoplasty, use this. Yeah. No problem.
Hello?
She will come.
Ghazal? Then we'll cancel our presentation. The next session is at 10 a.m.
It is infective, inflammatory, and other tumors like lesions. In infective, there will be any papilloma, then inflammatory, and
Okay.
एवढा दबार दिला.
Did you given the presentation in plastic? Did you given your presentation in plastic session? बट ठीक है कर लो जो है वो कर ले सुनेंगे हम ओके या नो प्रॉब्लम यू कैरी ऑन I think this is plastic. Enucleated eyes, yes?
Enucleated eyes.
Yeah, no problem. Let her present, yes?
Okay. Good morning, everyone. Respected panel, myself Dr. Ghazal Patnaik, and I shall be presenting our work on histopathologic immunohistochemistry study of an enucleated specimen in a case of end-stage pars planitis. So this background of this study was the fact that the pars planitis is expected as a subset of intermediate uveitis and without a systemic involvement. However, very little is known about the pathophysiology of the same, especially with the advent of the newer immunomodulatory therapy. So we did an observational case study of an 8-year-old male child who had a decreased vision since 5 years. He had undergone cataract surgery in both the eyes. The best corrected visual acuity was no perception of light in the right eye and hand movements in left eye, with IOP being 3 mm in the left eye. Slit lamp biomicroscopy revealed a thicical right eye with a total corneal opacity. Left eye had a band-shaped keratopathy with total occlusive pupillae. So as can be seen, the right eye B scan revealed a tractional retinal detachment, whereas left eye had numerous vitreous inflammation with a thickened choroid. Lab investigation was non-contributory, hence a diagnosis of pars planitis was made, and the child was given oral methotrexate along with adalimumab injection along with steroid, and then the inflammation was controlled and vision improved to 660. So as can be seen here, left eye had so much of inflammation, but this right eye, we all treat this right eye as a garbage and we just enucleate it. So that should not be the end of the story. That enucleated specimen should be evaluated further. Why? Because we know the pars planitis is a severe inflammatory condition that stimulates the glial cell proliferation, and because of this presence of lymphocytic proliferation with fibrosis, it supports the post-inflammatory glial proliferation. So histopathology of this enucleated specimen shows numerous glial proliferation in all the levels, and when we dig deeper, we see that apart from the lymphocytic proliferation, CD3 is positive, which is quite common in the literature, whereas CD8 positivity was also found in our case with CD20. What was new in this study was the presence of CD68, which was never documented in the literature, and HLA-DR positivity. So when we find these two type of biomarkers, this indicates that only steroids in any form is not sufficient. We need aggressive immunomodulatory therapy. So to conclude, pars planitis is a chronic inflammatory process, and it should be dealt aggressively and should not be considered as any other case of intermediate uveitis. And we elaborated the various pathological immunohistochemical biomarker from the garbage enucleated specimen, and we found that CD20, CD68 and HLA-DR positivity to be new biomarkers which can be used for future studies to understand the pathology and for the advent of new pharmacological therapies. Thank you. These are my references.
Judges, question please.
Yeah. Do you suggest enucleation for all pars planitis where it is chronic or thyssecal eyes?
Thyssecal eye, sir. As can be seen, the thyssecal eye was enucleated. The other eye had severe inflammation, but when it was dealt with aggressive immunomodulatory therapy, that could be salvaged. What was the main focus here? That only enucleation should not be the end point. It can be studied further so that it can help.
Typing need to be done.
Yes.
But clinically, if you don't go for enucleation, most of the cases do not require that severe
That's
step.
why, that's why we know little.
No. How do you interpret clinically this information without any enucleating the eyes?
Yes, sir. So first thing is severe inflammation not being controlled only with steroids. Whenever a child comes with inflammation in both the eyes, pan-uveitis like picture with severe vitreous inflammation which was present in the left eye, that should never stop at low dose suboptimal steroids alone. It needs immunomodulatory therapy at the beginning.
Now, can you take a retinochoroidal biopsy and subject the same thing for
Sir,
HLA
if
typing?
it would have presented in the earlier stages without the tractional retinal detachment, could be, but that needs to have a retinal lesion. In cases of pars planitis, they don't have any retinal lesion per se, and the snow banking is very adherent. So if inflammation can be controlled alone with the immunomodulatory therapy, there's no need for the surgical intervention.
Now, what I think is that if snow banking is there and you have gone for a partial vitrectomy and then take the sample and then do a HLA typing, is it possible?
So that's what it is possible, but no need.
Then why can't you suggest that as a future step for your extension to your study?
That is an invasive technology, sir.
No, enucleation is much more aggressive, right?
Enucleation is at the end stage.
End stage, that's what, you don't wait for the eyes to go to end stage and then enucleate.
Yes, sir. Before that
Instead, what I am suggesting is for your observation, to bring it to a clinical relevance, you suggest for a vitreous. For that, you need to require a follow-up study. Probably you talk to JB and suggest him that they should take the vitreous biopsy and subject for HLA typing.
Yes,
it may be possible.
Yes, sir, definitely.
See, one observation is good, but require this thing. If it is negative, then immunomodulators are not required. Positive, definitely that may be needed.
Yeah, Ghazal, I just wanted to add that you are telling enucleated specimens are a garbage bag. It's not like that. We always send each enucleated specimen for histopathology every time.
No. You do that in general. I'm saying you don't treat
That's
it like
not a
that.
garbage bag. We get so much information from the
Definitely.
Rather, any tissue which comes out should be subjected for histopathology.
The child was operated for cataract.
Yes, sir.
So was it a congenital cataract or a complicated cataract due to a pre-existing panuveitis?
We have no record, sir. Patient came with cataract being done elsewhere without any inflammation.
Can I know what is the possible cause of this pars planitis? Possible cause?
So that's what pars planitis is a subset of intermediate uveitis which does not have any systemic. It's mostly idiopathic.
Right, I think, thank you. I think we exceeded the time now.
Yes, yes, sir.
Mismanagement. This is also part of the management, time management.
Yeah, I will request Rajguru sir to hand over the mementos to our judges, please. Rajguru sir. Rajguru sir, please come on the stage. No sir. Dilla do. Yeah. I will request Tripathi sir to come on the stage. Dr. Patnaik sir is there. Photo kind. Photo to take. I have announced one. Okay. Now I would request sir to felicitate Pushpa ma'am, please. Pushpa ma'am. Now I will request sir to felicitate moderator of the session. Okay. Yeah, please hand over the memento to the moderator also, sir. Dr. Omega Presni, you can hand over the memento to her. Everyone, please stay back for a group photo. Bigya, you can join there. Sir, also, you are also one part of the judges team. I think you can join the team also. Ghazal and Mohez, are you there? Good evening, good evening. Over to Dr. Brutendu for the next session, free paper, vitreoretina. Dr. BNR Subudhi, free paper in vitreoretina.
Good morning all. Let's move to the next session. That is Professor Dr. BNR Subudhi Award for free paper in vitreoretina. I would like to invite the judges to kindly take the chair. Professor Dr. Ajit Babu sir, Dr. G.S. Das sir, Dr. Subhabrata Parida madam. Our first speaker is Dr. Sanghamitra Kanungo. I think she is not. Do we have Dr. Jyoti Prakash Behera? Dr. Amrita Pradhan. So you can keep it ready. If you have a connector, so the timing we will have 5 minutes. So is the timer ready? Okay. So you are ready? So you can start the timer.
Hello. Good morning, everyone. Today I am going to present our interesting paper, Real-World Economic Analysis of Diabetic Macular Edema and the Cost to Maintain Single Line of Vision. The global burden of diabetes mellitus is around 387 million. 93 million people are affected by diabetic retinopathy. In India, the prevalence is around 12.5% for diabetic retinopathy and 4% for vision-threatening diabetic retinopathy. No real-world data is available to assess impact of health scheme in Indian eyes. Very limited Indian literature reveal increased cost of care with disease severity and visual impairment. So our primary aim to understand the real-world economic analysis of diabetic macular edema and the cost to maintain single line of vision. And the secondary aim is to assess the impact of government schemes and community programs on diabetic macular edema care. And the objectives are the economic outcomes in patients with DME treated with anti-VEGF injection in Eastern India, to evaluate the cost incurred in maintaining single line of vision in such patients, to evaluate the improved or maintained visual acuity among paying and non-paying group. So coming to materials and methods, study area, this study was conducted in a tertiary care institute in Kolkata. It is a 2-year duration study. It was a retrospective cross-sectional observational study. 142 patients with diabetic macular edema was the sample size. Inclusion criteria being diabetic macular edema who was no treatment in last 6 months and having minimum follow-up for 9 months. Exclusion criteria being macular edema other than diabetic retinopathy, and who have patients with less than 9 months of follow-up, and other ocular disease like optic neuritis, glaucoma, ARMD. Methodology, it is an electronic medical record-based search of patients fulfilling inclusion criteria. We have categorized into 4 groups. One is CAS, second is government health schemes, third is insurance, that is Mediclaim, fourth is institutional community program. We have collected the demographic data and collected all the data regarding visual acuity, lens status, type of diabetic retinopathy, OCT, of macula at initial visit, at similar documentation done during 6 months and final visit. Then we have collected data received in form of intravitreal anti-VEGF, steroid, laser PRP, vitrectomy and cataract surgery. We have evaluated visual and functional outcome of patients and cost incurred in form of total clinical visits, OCT, cataract surgery, anti-VEGF received. And final data was analyzed by SPSS window. As patients across all groups received equal quality of care as part of uniform institutional protocol, cost analysis done in form of clinical visit, OCT, injection, laser photocoagulation, vitrectomy and cataract surgery. I have already discussed the mode of payment group. First is CAS, second is government health scheme. In our institution, payment done for only clinical visit and OCT. And third group is insurance covered by Mediclaim. Fourth is institutional community program in which all services are given by free of cost. Then in our study, total patient was 142, male to female ratio 77 to 65. Mean age of presentation was 57 years and mean duration of follow-up was 23 months. Mean age is 57 and we have calculated distance from hospital in kilometers, duration of diabetes, duration of follow-up, BCVA in logMAR, central macular thickness and total number of injection given, and total cost incurred and final visual outcome. And the final cost analysis was 70,000 INR in Mediclaim and CAS paying group. So problem statement is government primarily efforts focused on cataract blindness. No real-world data is available in Indian eyes to assess the outcomes of intervention in diabetic macular edema. Very few literatures are available. Only one Indian literature, LVVI group, has studied this, and mean cost was 60,000 INR. Our study was showing that maximum vision gain in community group followed by government scheme. Why this study asks? There is need for government and community support in diabetic macular edema care. And its study provides an invaluable data for policymakers to optimize government funding for diabetic retinopathy treatment. Our study limitation was, it was a retrospective study, single center and small sample size. So come to conclusion, government schemes and community support can help underprivileged patients to get same level of outcome as Mediclaim and out-of-pocket cash patient. This study provides framework for policymakers to allocate funding for diabetic retinopathy.
Questions? Very good. You maintained the time, that is very nice. You done a retrospective study. Actually, it is a data analysis which is available already with you. But even with that, 142 patients is very, very less number
Yes,
for this thing. Is it only Kolkata center or it's a multicentric?
No, sir, it is Sankar Netralaya, Kolkata only.
Kolkata only. That you need to specify. And second is the number of visits in this 1 year. How many visits happened with the patient?
Sir, we have only documented the first visit, then sixth visit, and final visit.
That really will not
yes, sir.
translate
That is the
into
limitation,
real,
yes, sir.
this thing. And how much is the vision loss in other groups if
Yes,
you
sir.
don't intervene?
111 patients have improved, and remain patients have not improved their vision.
No. What I am asking is,
Yes, sir.
without any interventions,
Oh.
are the patients losing vision? See, you are claiming that you are spending 70,000 for maintaining or gaining one line of vision.
Yes, sir,
Okay,
yes, sir.
so if we don't intervene, are they losing the vision? That's what you need to really prove.
Yes,
That yes, I have spent this 70,000 to save this vision.
Yes.
How can you state that? Right? Unless that other group is there, it's very, very tough. But the idea of this study is very good.
Yes, sir.
I appreciate it, but the number should have been more.
Yes,
The
sir.
comparative group should have been there, and each visit should be considered in analysis.
Yes, sir. Yes, sir.
Any other? Yeah, that's what. Travel cost is included.
Yes, sir,
Yeah,
included.
that's
All the
what
costs are
2
included.
visits, 3 visits they included. Rest of the visits they have not included. Okay. Yeah.
So, as now there is PM's health scheme for all, there will be no problem for this money.
Sir, actually in BSKY only ranibizumab is available. Other injection, other like steroids like Ozurdex, triamcinolone, that's are not available. So our study for policymaker to implement all the diabetic retinopathy care like steroid and all types of injection like Acentrix, Eylea, faricimab, the new anti-VEGF should implement.
It will be included.
Yes. Sir, we have calculated from starting from clinical visits to OCT, laser, FFA, all the. Why, sir? Sir, by SPSS, we. Sir, in our institution, the every patient have received one ranibizumab, or every injection we have calculated the cost of from by SPSS window. We have calculated, sir, everything from clinical data to everything distance.
Yeah. Okay. I think the time for discussion also will be 2 minutes only. It's not more than that.
Okay.
Yes. Okay, thank you. Next speaker.
I think the time is up. We will move to our next
Speaker,
lecture.
who is?
Next speaker, Dr. Santosh Mahapatra. Okay.
Santosh Mahapatra.
Can I have my presentation?
In the meantime, I would request all our attendees to kindly maintain silence. Sometimes there is some discussion going on that actually disturbs the judges and everyone.
Mobile silent mode.
Mobiles also in the silent mode, please, and enjoy the talks.
Timer दिख रहा है? Babu. Good morning. Can I start or you will give the timer? Okay. Good morning, everyone. I am going to present my Good morning. The topic of my presentation is extended silicone oil tamponade, a solution for minimizing retinal detachment or not. As you all know, despite continuing advances in vitreoretinal care, Rigmartin's RD remains the major cause of visual loss worldwide. And the most commonly used treatment is vitreoretinal surgery along with tamponades. And among the tamponades, silicone oil is the most preferred tamponade, but it is associated with complications like secondary glaucoma, cataract formation, corneal decompensation, and oil emulsification. The removal of oil is advocated usually after 90 days to reduce complications like mentioned. But the risk of retinal redetachment post-oil removal is significant. Moreover, re-IRD is a detrimental complication that completely undermines the initial efforts. With this background, two study questions come to our mind. Can silicone oil be kept for an extended period without significant increase in rate of complication? And can the delayed silicone oil removal statistically decrease the rate of redetachments? And with this, we try to conduct a hospital-based prospective comparative study, taking 100 cases in each group over a period of 12 months from August 22 to August 23, with a minimum follow-up period of 6 months. And the randomization was a simple randomization. As the cases come, we put them into inclusion and exclusion criteria to include them into the study. And all cases with rhegmatous detachment are included, with or without PVR, but other causes of retinal detachment were excluded, and all cases who had uncontrollable IOP following a silicone oil injection are also excluded from the study. All the demographic parameters of the patients, including ocular and systemic evaluation, were recorded in our case sheets. And the group 1 had silicone oil removal after 3 months, and they are followed till another 3 months. The group 2 were kept, the silicone oil was kept for 6 months at least, and after that the oil was removed. And the results following these are compared. As you can see, the male and female ratio in the first group was 2:1, and the second group is 2:1. The visual acuity at presentation is almost comparable from 2/60 to hand movement in group 1 and to PL in group 2. And mean IOP following oil removal in both the groups were also comparable. But 30% of the patients had redetachment following oil removal at 3 months in group 1, while group 2 had only 3% redetachments. The IOP were very much comparable in both the groups, but the significant re-IRD was seen, as you see in these cases. Apart from PVR, high IOP, cataract and BSK, all other parameters were almost comparable except retinal detachment. So, retinal reattachment is recognized sequela of oil removal following redetachment. And we have done an extensive case, research of the articles related to this, but we have found only few, less than 10 articles. And I'll just put 3-4 in contrast to our study. The Clement et al. Suggested that redetachment rate is 14.9% in 17 eyes that underwent silicone oil removal within last 3 months. And the history of unsuccessful surgery was the significant cause. Like Hang et al. Stated that redetachment rate is 18.5%, but they concluded no preoperative or intraoperative factors influence the risk of detachment. Other studies stated that the redetachment rate is 17.4% while the mean duration of tamponade is more than 6 months. And the authors recommended not to apply standard criteria for timing of silicone oil removal. The limitation of the other studies which we found are not pertinent to Indian subcontinent, as most of the patients come to us with a advanced retinal detachment stage with PVR. And in those cases, oil retention can be a better option. So, the oil can be retained beyond 6 months if there is no further complications like cataract formation, high IOP, corneal decompensation. And the cases can be followed up beyond 6 months if you are not having any complication, and particularly so in pseudophakic eyes. Thank you.
Perfectly in time, Dr. Santosh.
Judges' questions,
I just
please.
have a doubt, like yours is a
I'll take the judges' question first, sir.
Yeah. So perfectly in time, Dr. Santosh. I have a question, like yours is a prospective study, right? So you selected the patient to whom you will go for 3 months, before 3 months oil removal or after 3 months
It
oil
is
removal?
only simple
So how did you
randomization.
Okay.
It is first patient I take oil removal,
Yeah.
second retention,
So it is
third removal, fourth retention.
You-
This is very simple randomization.
in that way,
but
randomized way
but
only
all the
without
patients who do not satisfy the inclusion criteria just I have
that,
showed
that
are
part you
excluded.
said. I just wanted to
Including the
know-
patient who, suppose I have included a patient who in group 1, but seen that the IOP is uncontrollable following all injection, they are
Those are
removed.
excluded.
They are
Yeah,
excluded.
That
Yeah.
part I am clear. Those the area. I just wanted to know how you selected the patient because as it is a prospective study.
Madam, after selecting the inclusion and exclusion criteria, the patients who were been operated between the period I mentioned were selected in group 1 and group 2 alternatively, unless until they are fulfilling the exclusion criteria.
Okay. Postoperatively, you planned in that way.
Yeah, we will.
Because you have must have selected
Yes,
and
yes.
followed
First
the
group
cases for
we removed
studying.
the oil after 3 months. Second group we retained the oil beyond 6 months.
Okay.
It's a good study, thinking that keeping the oil for longer time. But whatever practical purposes, 2 weeks to 3 weeks is just sufficient. So in your comparative groups, wherever there is a redetachment after silicone oil, did you analyze what could be the reason for redetachment?
In eyes which
the
had
eyes had redetachments in between both the groups.
After
Did you
removal of-
analyze after the removal of the oil, what is the reason for redetachment? Is it the duration or something else which is cause for this thing? Then the duration do not come into major play. So did you analyze that?
Yes, sir. We tried to analyze, but as we have seen, presence of PVR can be one of the causes, but the duration, most of the time, when the duration is less, I think there is a redetachment, and that we have tried to plot into a graph.
Yeah, what I say is that under the oil, if around the break there is a fibrosis, even after oil insertion, that can be there, or there can be a partial closure, which this thing added an inferior fluid, or if there is a pre-retinal fibrosis, these kind of observations, if they are there, probably that may cause redetachment in general cases. Whereas
sir.
by keeping 3 months or 6 months, even in the presence of all these findings, if it is making a difference, then it becomes a significant.
Sir, that is what is coming in the results, sir. Without any significant PVR changes, just like the points you have pointed out, we are seeing redetachment more in all removed eyes than in all retained eyes, and that is why the study.
Means, it is to some extent it is saying that keeping oil for a longer period, does it prevent PVR so that it is
Yes, sir.
preventing
Yes,
recurrent
madam.
RD?
That is already, oil is anti-PVR, it is already there, that point is already there in previous studies, and I think it is also contributing to the thought of our study.
We should move on to the next talk. Actually,
Yes, even after this silicone oil tamponade, sometimes cataract occurs as a complication. What is the type of that cataract in comparison to normal cataract?
It is mostly posterior subcapsular and opacification of the
Consistency of the cataract.
Sir?
How it is different from the normal cataract?
Normally, the normal cataract is nuclear, but it is most of the time posterior subcapsular in silicone oil filled eyes.
It is very tough like plastic.
Sir?
Yes.
Okay, thank you. Thank you, Dr. Santosh.
Yes, sir. That is, yes, sir. That is opacification.
we'll move on to the next talk.
extend kala pore
ତାହେଲେ ଇଏ ଲଗେଇଦେବା କହୁଛ ପେନ୍ ଡ୍ରାଇଭ୍ଟା ପେନ୍ ଡ୍ରାଇଭ୍ ଲାଗୁନି
ଆସିଥିଲା ମଝିରେ
ଆସୁଛି କିନ୍ତୁ ଆମର କିନ୍ତୁ extend କଲା ପରେ ସେଇଟା ଅଛି ଏଥିରେ କି ଏବେ ଟିକେ ଗୋଟେ ମିନିଟ୍ ସାର୍ ସାର୍ କୋଉଟା
ଅଶୋକ ହଁ ଏଇଟା ହଁ
ବନ୍ଦ କରିଦିଅନ୍ତୁ ସ୍କ୍ରିନ୍ଟା ପକେଇ ଦିଅନ୍ତୁ ଏଇଟା ଆପଣ ନେକ୍ସଟ ପ୍ରିଭିୟସ୍ ଏଇଟା ମାରିଲେ ଚେଞ୍ଜ ହେଇଯିବ ଟିକେ ଗୋଟେ
I hope it's ready.
Good morning, everyone. Sorry for the technical glitch. Today, my topic is by simplifying scleral buckling by a novel technique. So, it will be reviving a dead art. Financial disclosure nil. So, my study question is how many of us are aware of the SPR study, which states that scleral buckling alone is sufficient in cases of rheumatogenic retinal detachment, which is uncomplicated and phakic cases, and it does not require PPV, and the BCVA is better than pars plana vitrectomy. We know the result of the study. So, but how many of us follow the recommendation of the SPR study? This study question is because nowadays we are inclined towards the pars plana vitrectomy route most of the cases. So, the current modalities of the treatment of rheumatogenic RD are pneumatic retinopathy, scleral buckling, and pars plana vitrectomy. During the last few decades, the pars plana vitrectomy has gained popularity. This is because of all of this reason. There is a paradigm shift towards the pars plana vitrectomy because there is a better ergonomics in teaching and learning the pars plana vitrectomy. And in scleral buckling, it is required to localize each break accurately, which is not required in pars plana vitrectomy. The scleral buckling has a slow learning curve, and it's not suitable for complicated RDs. So, still, is there a place of scleral buckle in RRD management? Yes. In these cases, like in young patients, uncomplicated recent onset RDs, phakic lens status, and where there is a clear crystalline lens, and to avoid silicone oil related complication and general complication of the pars plana vitrectomy, and avoid resurgeries. So, principle of retinal detachment surgery, we have to relieve the principles are relieve traction on the brake, bring RPE close to the detached neurosensing retina, and create adhesion between the retina and RPE choroid. So, we achieve this by in vitrectomy and scleral buckling by in vitrectomy we achieved by vitrectomy, and the corresponding procedure is placing a buckle. In vitrectomy, intraoperative tamponade given by PFCL, and after long-term tamponade given by silicone oil. And the tamponade in scleral buckling is given by is draining the subretinal fluid. And adhesion is created in vitrectomy procedure by laser, which we achieve in scleral buckling by cryopraxy. So, why scleral buckling appear to be difficult? So, in PPV procedures, all the procedures like vitrectomy, intraoperative tamponade, and lasers are done in direct visualization. But in scleral buckling, these two procedures like placing a buckle and cryopraxy can be done as a direct procedure under visualization. But this process of subretinal fluid drainage is a blind procedure, and it is the most difficult and inadequate step in scleral buckling. So, we in our study we concentrate upon this subretinal fluid drainage procedure. So, current technique, what is the now how we do the SRFD by cut down technique or needle drainage technique. So, what is the difficulty in the current technique? Difficulty is a risk of choroidal hemorrhage, inadequate subretinal fluid drainage, inadvertent perforation of the retina, and creation of new break and vitreous incarceration into the drainage site. So, can we improvise this technique by the technique which I am going to demonstrate? So, under direct monitoring, as the usual procedure, we perform the peritomy, muscle bridle suture, cryopexy, and placement of buckle as per the need. And then we come to subretinal fluid drainage. So, my procedure describes a do-it-yourself guarded needle SRF drainage and maneuver. So, the material requires are 23 or 25 gauge infusion line, which you usually use in the PPP procedures, 2 ml syringe, which attach 24 gauge needle, a caliper, a marking pen, and a cutting scissor. So, these are the instruments which required for this my procedure, which is readily available in any vitreoretinal OT. So, this procedure I will demonstrate because the time is less, so I will go to the video. So, this is by doing after peritomy, doing the then place the muscle bridle suture, then place the buckle, then take a needle with a syringe with the piston removed and insert the infusion line and cut the infusion line at the tip of the needle. Sorry, I'm late. So, measure 2.5 to 3 mm from the tip and cut again so that it exposes the the advanced 2.5 to 3 mm of the needle tip. Then insert the needle. And you can see the drainage of the subretinal fluid with an easy and a safe technique. As the needle is guarded, it will definitely not pierce the vitreous cavity or touch the retina, so that the perforation of retina and incarceration is avoided.
You need to conclude.
Yes, sir.
I think we'll
time is up.
Go to judges' question now.
No, we will not ask any questions because he exceeded the time.
Okay, thank you. So, the next speaker is ready. Do we have Dr. Sugandh Kashyap, Dr. Anshuman Mahapatra, okay. Dr. Sanghamitra? So, Dr. Sugandh, kindly make your presentation ready on the other side.
Should I start?
Yeah, sure.
Good morning, everyone.
Please keep the timer on.
Okay, so my topic is role of serum cystatin C as a biomarker for diabetic retinopathy from a rural Indian population. No financial interest. As we all know, the statistics of diabetes and diabetic retinopathy is on a high rise, and we have limited VR surgeons all across. Screening for diabetic retinopathy is a real challenge. Adding to that, the economic burden is significantly higher the patient with sight-threatening diabetic retinopathy compared to the non-sight-threatening diabetic retinopathy. A special mention for Tier 2 cities and rural areas where logistics and facilities for availing the treatment is really a challenge. We all know there are several risk factors associated with diabetic retinopathy, including age, duration, estimated GFR, HbA1c, and all. And we have numerous circulating biomarkers in the blood. Those are coming up recently. And out of this, cystatin C is something which needs a mention, because in the recent papers, especially the Gurdas et al. In JAMA Ophthalmology, just a couple of years ago, they have found it significant. So with this, the aim and objective of our study was establishing the role of serum cystatin C as a systemic biomarker for diabetic retinopathy and its role in the early detection and management of diabetic retinopathy, thus reducing the financial burden and improving the visual prognosis. One line I want to mention over here, because diabetic patients come to the physician first. Physician advised a battery of investigation, blood investigation. Can we find out the role of cystatin C, serum cystatin C? That's why we did this study. So it's a cross-sectional study, total 112 patients from June 2023 to August 2023. The patients were recruited from two cohorts. Number one, the patients with diabetes visiting a physician, that is diabetologist clinic in Sambalpur, Odisha. Cohort number two, patients with specific complaints related to diabetic retinopathy and visiting the retina clinic of Trilochana Netralaya, Sambalpur, Odisha. Fundus examination was done by a fellowship trained surgeon, that is myself, and blood investigations were done. Coming to the cystatin C, this is the machine in which the cystatin C was done, no financial interest, laboratory staff was blinded. Normal range according to the laboratory finding is 0.55 to 1.15. So this is in a nutshell, total 112 patients, first cohort 57, second is 52, and second cohort, all the patients had diabetic retinopathy. First cohort, 9 patients with the 18 eyes had diabetic retinopathy. So known DR was 51 and diabetic retinopathy was 61 patients. Sorry for this busy slide, but the left side of the slide tells all the parameters, including the blood investigation, age, and the medications. Those are not significant between known DR and DR. However, the significant findings were hemoglobin, HDL, and serum cystatin C. We can see the p-value is significant. Coming to mean cystatin C, if we can compare between known DR versus DR, the p-value was significant in the DR group. That means serum cystatin C was higher. If we divide the serum cystatin C levels into different tertiles, tertile 1, 2, and 3, the patients with higher serum cystatin C were having higher odds ratio of having diabetic retinopathy. So we proved it either way. So coming to the discussion, there was significantly higher serum cystatin levels in patients with diabetic retinopathy, similar to the previous studies, probably because cystatin C is related to diabetic nephropathy, and this microangiopathy involves nephropathy, cardiopathy, and retinopathy. That's why probably cystatin C is involved. That's the mechanism how we can see. So hemoglobin is low in these patients, we know, and we advise hemoglobin. HDL is surprisingly higher in these patients. That is ascribed to the different heterogeneity among the various studies conducted. Coming to the limitation, cross-sectional study and relatively small sample size are limitation of this study. To conclude, there is a significant association between elevated serum cystatin C and presence of DR, and these findings suggest that probably serum cystatin C can be included as a blood investigation during the workup of a patient with diabetes. Thank you.
Yeah, thank you, Chittaranjan. Actually, it's very well thought of study. Only I am not very clear about this study, how the patients, where the machine was kept. Is it in your clinic or in their clinic or a neutral place? Number one. Number two is, you said diabetic retinopathy present or not. What was the duration of the disease? Third is that you said nephropathy is mostly associated. So what are the microalbuminuria or this creatinine levels that the patient is having? Means if these gaps, if you can clear.
I can clear all the gaps. Coming to the number one question, so it was, as you told, it is a well thought of question. Before that, I will add that who paid for the cystatin C. So when we started with this machine, same machine, this machine was there in our hospital, that is Trilochana Netralaya. So all the patients coming to us, we will definitely do in this machine. But when we collaborated with the physician, we asked the sir how to do. Can we send all the patients? So there was a problem. All the patients are not willing. So that physician was good enough, he purchased a similar machine from the same company, and all the patients he did free of cost to the patients. Same company, that's why I told that it's the same machine. The company name also I have written over there. Coming to the second, you asked that microalbuminuria and creatinine. So that busy slide I have told, all the investigations we have done, including urea, creatinine, all the HDL, triglyceride and all, they were not statistically significant in between these two groups. So what was finding?
The duration of diabetes among the patients 57 and 52, because your clinic 57, his clinic 52 patients are there.
Yeah.
What was the duration and type of control of diabetes?
Yeah, so
how was it?
Duration of diabetes and type type of control, that is one thing, yes, that is, as because it is a cross-sectional study, probably that is a limitation. If
No,
we find...
still the data can be collected actually.
Yeah. You are right, sir. We can work on that. That's why it's 112 patients. Probably with a multicentric study, we can include more patients.
Don't make it multicentric first. One-centric, a perfect study is better than multicentric study.
Yeah, yes, sir.
Okay.
Thank you, sir.
This data, if you collect, what will happen is, later on, means retrospective data analysis can be done at any time.
Yes,
Actually,
sir.
now you can go back and again look into all the factors of these patients.
Yes, sir.
So that you can come to a relevant conclusion.
Yes, sir.
And what is your future plan that cystatin is significant, let us say? What is your future plan?
So my future plan is that, as I told, it's cross. If we can follow up these patients, because we have all the patients' data, their address, they are compiling with us. So we want to see the patients, those who are having mild NPDR, how they are progressing. Or if somebody is having no DR, how they are progressing to the advanced stages of DR. That is my first thing. And if someone is having DR or this thing PDR, how they are behaving in comparison to the other group, other patients who are having normal cystatin C, and this patient is having high like PDR, advanced PDR with high cystatin C, how they are doing surgically, after post-surgical intervention, how they are doing. I am going to analyze all this data. Because
actually, this thing with collaboration with the nephrologist, even the duration is longer and there is no diabetic retinopathy. Certain times they are doing the biopsy and they are proving that this nephropathy is because of some non-diabetic causes. So cystatin may be raised in those patients also.
Yes.
How do you rule out that?
So yes, that's a very valid point, sir. So as we are not physicians are better learned in than us in this matter.
We are
so
time. Next,
maybe we have to find out what are the other causes than diabetic retinopathy which is contributing to the nephropathy. And yes, that is a possibility. So many other systemic biomarkers what we studied, like hemoglobin, HDL, triglyceride, LDL, and
we need.
Yes, sir. Yes.
Your interest is one, and we are focused on that whether you are done good or not.
Yes, sir. Thank you, sir.
I think we'll go to the next talk.
Yes. Sugar.
Please start.
Yes, sir. Thank you. Thank you.
Start the timer, please.
That's all. Can I? Thank you.
Good morning, all.
No.
Okay. Good morning, all. So today I am going to present a study on the hematological and clinical profile of aggressive retinopathy of prematurity. So I have no financial disclosure. So in this era of modern medicine, a pediatrician is happy saving a preterm baby, but at the same time, we ophthalmologists are getting nightmares in the name of retinopathy of prematurity. And it becomes night terror when it is aggressive retinopathy of prematurity. So what is aggressive retinopathy of prematurity? It is a severe form of retinopathy that affects very low birth weight preterm infants. It develops rapidly with prominent vascular changes and extends posteriorly. It does not progress through the classic stage of 1 to 3, and the posterior pole vessels shows increased dilatation and tortuosity in all the 4 quadrants. And it can lead to early vision loss if not treated promptly. So these are the stages of the ROP according to the ICROP classification. Coming to introduction, in a developing country like India, there has been a rise in the incidence of retinopathy of prematurity due to development of neonatal care units and increased survival of babies. So ICROP recommends the screening of infants of less than 1750 gram or gestational age less than 34 weeks, as well as at-risk infants outside this criteria. AROP is characterized by its atypical presentation and aggressive nature and can lead to severe visual impairment or blindness. Anemia, thrombocytopenia, poor weight gain, and presence of systemic infections can contribute to development and rapid progression of ROP. So my aim was to find out the hematological and clinical profile of the patient who are reported to OPD, NICU or SNCU and having the aggressive retinopathy of prematurity. So material and method used were, it was a prospective observational study which was done from March 2023 to August 2024, and according to ICROP, all preterm infants of less than 34 weeks and birth weight less than 1750 gram were screened at OPD, SNCU and NICU. Birth weight, hematological findings, systemic conditions, blood product infusion histories and retinal findings were recorded. Infants developing or showing progression of AROP were included in our study. So these are the pictures where we are doing the screening at the OPD, NICU. And these are the of our finding report where we got zone half APROP with pre-retinal bleed, zone 1 AROP and zone 2 AROP. The patient profile includes 250 patients, among which the male is to female ratio was 142 is to 108, and the mean birth weight which we got was 1000 gram, and the post-menstrual age during presentation was 28 weeks to 34 weeks. And the number of babies we have got with AROP were 27. So in the patient, of 9 AROP, we got hemoglobin less than 8 gram per DL. In 15, we got hemoglobin 8 to 10 gram per DL, and in 3 patients, it was ranges from 10 to 12 gram per DL. MCH value was less than 31 picogram in 18 patients and more than 31 picogram in 9 patients. And platelet count was less than 1,50,000 in 10 patients, in the range of 1,50,000 to 4 lakh in 12 patients, and more than 4 lakhs in 5 patients. Also, we found weight was less than 1,000 gram in 18 patients and 1,000 to 1,500 gram in 9 patients, and CRP positive and CRP negative were also seen. Associated risk factor which we discovered during our study was like respiratory distress syndrome, poor weight gain, NICU stay more than 1 week, and antibiotics were also given. So coming to discussion, microcytic hypochromic anemia can cause fluctuation in oxygen levels and cause increased oxidative stress leading to development of AROP. Thrombocytopenia result in vascular instability and dysregulated angiogenesis, which can also lead to progression. Sepsis also contributes through inflammation, oxidative stress, impaired oxygenation, and intensive care medical interventions. And poor weight gain in preterm is an important risk factor for progression. So coming to conclusion, as hemoglobin level and MCH play a crucial role in the oxygen transport and low level of this may lead to increased risk, CBC can be a simple and easy, reliable and reproducible tool that can predict the development of AROP. And it can help pediatrician and even non-trained ophthalmologist in predicting the development. Can be used as a beneficial tool for timely detection of the treatable AROP. These are my references. Thank you.
Okay, it's a good study actually, but how you stratify the data,
Sir, it
which was
like,
not very clear.
Sir, it is like the patient which reported to the
You
OPD.
said the number of patients with poor anemia, poor hemoglobin percentage, platelet count and all. But while analyzing the severity of the ROP, how you stratified that these are the factors which can be very contributory?
No, sir. We wanted to know that the patient we presented with the aggressive retinopathy of primary, does those people were having less hemoglobin or less platelet count or less picogram, excluding it from the other forms of
And
ROP.
weight gain also you said.
Yes,
See, in the discussion
poor
you-
weight gain. We got in the of those 27 people who were babies who were having the aggressive retinopathy of prematurity, we only calculated and means we data analyze of those patients' reports of the blood report, their history of any blood infusion or their weight gain during the next 7 days of follow-up, that whether they are having the same or they are progressing more.
No, I will reverse the question now. Okay. One, you said good hemoglobin, good weight gain, and even the good platelet count. Did it protected since your patient base is APROP? So even in spite of having good levels, they are having APROP. What could be the reason?
Then it may be some other factors which also included.
See, your study got wasted, right? Yes. That's what I'm asking you. You need to rule out and say, pinpoint, it is definitely a cause for aggressive APROP. Okay? That probably is missing in your study. Okay?
Sir, can we go to the
Right.
next
Yes.
one? Please. Okay, best.
Good morning to one and all. So, my topic, as we see, is central serous chorioretinopathy. And whenever we see a patient of CSCR in our OPD, we inquire whether he is taking any form of steroids. And we ask them to take them off the regimen. How about I say that, can we treat CSCR with steroids? The answer is yes. However, we have recommended treatment modalities like the photodynamic therapy, the subthreshold micropulse laser, the transpupillary thermotherapy, but it has its own pros and cons. And the newer treatment modality on the block, that is the intravitreal dexamethasone implant, has shown promising results. So, to evaluate it, we wanted to study the safety as well as the efficacy of multiple intravitreal dexamethasone implant in CSC patients. This was conducted in the L.V. Prasad Eye Institute, Bhubaneswar, was a retrospective study done between January 2022 to December 2023. And the patients presenting with chronic CSC were included in the study. The study complied with the tenets of Declaration of Helsinki and was approved by the Institutional Review Board. We included patients with chronic CSC, aged more than 30 years of age and presenting with SRF on OCT and having a minimum duration of disease of 3 months. Also, the cause of decrease of vision had to be primarily attributed to CSC. Patients with choroidal neovascularization were excluded from the study. The primary outcome here was the complete resolution of subretinal fluid at or before 3 months. And in secondary outcome, the optimal resolution was defined as reduction in the subretinal fluid more than 20% of the baseline value. In the 2 years duration, we were able to gather 9 patients, out of which we had a male preponderance, and the median duration of symptoms was 13 months. So, all patients received dexamethasone twice, and optimal result were seen in all patients after first injection. Upon second injection, we achieved complete resolution in 6 out of 9 patients. As we can see here, the trends of the change in mean subretinal fluid height, the change was statistically significant when compared with baseline after first injection and the second injection. Adjoining it is a serial OCT image of a gentleman of 39 years old who after first injection had complete resolution of SRF. And the subretinal fluid again reappeared, which after injection was resolved, and the macula remained dried up to 8 months after the injection. And the vision was also maintained, which was 20/20. Similar trends were also observed in the mean central macular thickness, which was found to be statistically significant reduction. The change in visual acuity and subfoveal choroidal thickness was not found to be statistically significant in our study. 2 patients did develop cataract, and the rise in intraocular pressure was experienced in 4 patients, but it was adequately medically managed. So, concurring the recent reports, we also had favorable response to dexamethasone implant with multiple injection in patients with chronic CSC. We achieved a better outcome when compared to the PLACE trial, where the subthreshold micropulse laser was employed. When compared to half-dose photodynamic therapy, we had almost similar response, and looking at the unavailability of PDT, the dexamethasone implant can be a viable alternative. Also, consecutive dexamethasone injections helped in enhancing SRF resolution. Also, it helps in resolution of intraretinal fluid, which is a sign of chronicity. Though we saw a rise in IOP in a higher significant proportion of our patient, all of them were medically managed and none of them required any filtration procedure. Thus, I conclude multiple dexamethasone injections can be safe and efficacious at the same time in treatment of chronic CSC. And there is no risk of exacerbation of the disease per se, with complete resolution of subretinal fluid in majority of cases. Thank you.
Ansuman?
Yes, ma'am.
Yeah, you told in your study. In your study, you told that if CSR persists for 3 months, then you tell them as chronic CSR and considered of injecting DEXA implant.
Yes, ma'am.
As per your study.
Yes, ma'am.
But my experience says that even if the first attack of CSR takes 3 to 6 months for complete resolution of the fluid, even without any treatment.
Yes.
So, actually, are you planning to inject DEXA implants in first case of CSR when they present, if they persist for 3 months or more?
So, ma'am, so that was our, thank you for the question first of all. So, when we started the study, we saw that there are multiple interventions for CSCR patients. But in case of chronic CSCR, when patients cross the timeline of 3 to 4 months, we have variable response. Few patients do respond well, and there is resolution of SRF. but many of the patients don't actually get resolution. So that's the reason
Have
why.
you seen anyone worsening after giving DEXA implant?
Worsening not in terms of the increase in subretinal fluid or so, but there was worsening in visual acuity in terms of cataract. All other things, all the patients, 9 patients, had better visual acuity in terms of or revival in terms of subretinal fluid resolution and the mean central macular thickness.
And do they recur with some other area leakage?
Yeah. First, as I said, after first injection, all of the patient had optimal response. 3 of them had complete response. And as I showed in one of my case, the patient had recurrence of it. But it again, after injecting, the SRF completely vanished. And even after 8 months of follow-up after the second injection, we found no SRF at the last follow-up.
And some of your photographs also, I saw mostly they are looking like acute CSR rather than chronic.
Yes.
Okay, thank you.
Thank you.
Then there was a circular from Dr. T.P. Das, both few years back. Once diagnosed CSR, no dexamethasone should be given. It was circular to all ophthalmologists. Don't give dexamethasone in any case of CSR when diagnosed, in uniform. So now you are contradicting his statement when Dr. T.P. Das has given circular that no dexamethasone, no steroid in CSR case.
You are right, sir, but and thank you for the question. In Sanskrit, we say kantakam kantake vaidam. And every new modality is challenged by the conventional thought. In an article, recent paper in the past by Spade et al., they have proposed that there is a presence of para-inflammation, which is when there is mounting of an innate immune response in patients of chronic CSCR, which leads to the chronicity of the disease. So our attempt here is to deal with that para-inflammation and that immune response, the pro-inflammatory cytokines which are released due to the chronicity of the disease. We did achieve good results. We did achieve good resolution in subretinal fluid. And towards this, that's why we also included the safety profile of the patients in this study. And to our surprise, the increase in subretinal fluid, the increase in intraocular pressure was adequately medically managed, and none of our patient required any filtration procedure in the study period, sir.
We will be requiring more clarification from Professor T.P. Das.
Sir, we also want to increase the number of study participants.
Okay, I think we will conclude the session here. We will go to the next session. I would like to invite our respected judges, Dr. Gunsagar Das sir, Dr. Ajit Babu Maji sir, and Dr. Subhabrata ma'am to kindly come on the stage for some mementos. Dr. Subalkar sir to kindly give the mementos.
उससे पूरे काम कराओ और कुछ घंटा भी नहीं दो, ये ठीक बात नहीं है। फोटो हो गया? उठा दिया, विज्ञान वो तो इनॉग्रेशन में आएगा, अभी नहीं आएगा वो।
Hello. Next we have ARC session. No, ARC session here. Dr. Bhavankule is our guest. So he is going to arrive. We have to wait for him actually.
After that, live surgery.
Yeah, after the live surgery will be there. Dr. Bhavankule is the speaker.
He's not there, but rest of the people are there. Now, how can you say it is not there? Yeah, we
He
can
is the
start.
speaker actually. He is the only speaker.
Only speaker?
Only speaker of the session.
Then why you have given him? Give a red mark to Prashant. Sachi, I will tell him. I have no hesitation. Only speaker and not being there is not a good thing.
Santosh sir has gone.
No one, no other speaker is there in that session.
Huh? He's in the camp. Wait करेंगे ना. We will wait. Yeah. No, we will wait for him, but otherwise. गाना हो जाए. रेडी है तो आने दो. 2-3 minutes. That's it. And he should cut short his presentation. Three talks are there. Panel भी है ना? अगर वो पूरा काम करेगा तो मैं क्या बोलूँगा? नहीं सर, we'll make it like that 6 minute वाला thing. 6 minute या 8 minute. उसका details क्या? Actually, where is this guy? Pretend. कौन से इसमें? अच्छा तीनों साथ है. सपना मांगो. हाँ ये तो मैं कुछ तो बोलना पड़ेगा ना. पैनल में फोटो क्यों रखा है आपने? फोटो अगर नहीं रखना है तो वो अलग बात.
And sir, this is one thing. What is happening is that we are sticking to the time.
100%.
So not miss that flow.
आपने भी बोला ये कि मुझे चाहिए कि टाइमर रखो बस. बाकी मैं देख लेता हूँ. ठीक है.
Something which has happened very good.
और प्रेजेंटर को क्वेश्चन नहीं पूछा ना. सीरियस सब लोग ऐसे ही करना चाहिए. Should be like that. He is my close friend. Biggest friend. फिर भी मैं उधर टाइम एक्सीड किया तो मैं
ଏମାନଙ୍କୁ ଦେବାର ନାହିଁ କିଛି ଖାଲି ତାଙ୍କୁ ହିଁ ଦେବାର ଏଇଠି ଲେଖା ନା ନାଇଁ ଲେଖା ହେଇଛି ଖାଲି ହେନ୍ତା ଫାକଲ୍ଟି ଯେନ ସେଇଟା ଦେଇଦେବା ଚେୟାରମ୍ୟାନ୍ରେ ଥିଲେ କି ପ୍ୟାନେଲ୍ରେ ଥିଲେ ଫାକଲ୍ଟି ଦେଇଦେବା.
I'm sorry.
ବାକି ଆଉ କାହାକୁ ଦେବାର ଅଛି
No, nice. हल्ला नहीं करेंगे, but he will get only time that is saved. Bas, we'll start the session on time. जो भी है, no. It is not for that. Say that when you are time expect करो बस. No, he's coming, it seems. 5-10 minutes. बाकी 20 minutes करेगा. Out of 3 presentations, he may do 1 presentation. Doesn't matter. Session, we will not exceed this session time. Yeah. Nice, sir. No, नहीं करो. No. It should not be done. Madhu Smith. We should stick. Pranamita. I'm sorry. तो वो है ना, जो टाइम पे खत्म होना है खत्म करना बस. If he comes late, we will say we are sorry, you are late. So this 10 minutes only you are getting out of this 30 minutes. So that even the national faculty should learn that yes, Odisha sticks to this time and I cannot take it granted. बिल्कुल 100%. ऐसा होना चाहिए. और क्या?
Instruction, Pranamita.
Clean. Yes, sir.
Stick to time.
Stick to session time. We are on time till now. आप टेंशन
Keep the finishing point at the end, like 11:30.
We will handle, no? We will.
Yes.
देखा, madam
person, we are expecting the time.
We are managing. Yes. Like that. We ensure that everything going well.
Because our term is coming after cutting.
अच्छा, हाँ.
Drought का term is after cutting.
अच्छा, फिर लास्ट टाइम संबलपुर में हुआ था ना, उस वो क्या संबलपुर वाला है, कटक का राउरकेला चाहिए, हाँ. देख लेते हो. वही तो प्रॉब्लम है. आप वो बात नहीं करना.
Extremely, sir.
You have 20 minutes for this session. You are late by 10 minutes. So we are cutting down the 10 minutes. जितना भी आपका होता है वो कर लो. ये फूल क्या है आपको वो ऊपर लगा है डाला. ये देखा no problem. Please get ready. Two presentations will come. Sir, good morning, sir. Yeah. Let him save time. Now, whatever time he saves, that will be his additional. Oh, really?
That place is
Quite far, actually. लगा दो. बस. Yes. Start the introduction. Yeah.
Good morning, everyone, again, we are happy to receive our speaker, Dr. Prashant Bhavankule. He needs no introduction. So he is having 3 talks back to back in the same session. The topics are management of iris abnormalities. Second one is management of traumatic
Only
cataract.
2 talks he will do.
Third one, he can manage, I think, in the time.
He cannot.
11:30 is the last
He
time.
is chairman ARC, I know, but he cannot manage
Okay.
3 talks in 2
Okay. So in this session, we have Chairman Dr. Subalkar sir and Co-Chairman Dr. Simon Behra sir. And in the panel, we have Dr. Ajit Babu Maji sir, Dr. S.T. Murlidhar sir, Dr. Subhaprata Parida madam, Dr. Sangamita Kanungo madam, Dr. P.K. Sarma sir, and Dr. Sabyasachi Patnaik sir. And moderators, myself and Dr. Brutendu. May I request all the panel and chairman, co-chairman to please take the front row, please. Yes, I think Sarma sir, you please come. Sangamita, yes, everybody is there.
चित टाइमर लगा दो ना 2 talk का जितना टाइम है 16 minutes 15 minutes है अभी
बोल देता हूँ।
ये क्या हो गया भाई?
2-3 minutes
Okay. Keep 2 talks.
2 talks. 2 talks. ROP वाला बोल लेते हैं.
And ये वाला traumatic cataract, iris. ROP you want to take? Iris abnormality. So we have 2 talks by Prashant sir. First one will be 3D vitrectomy for stage 4 ROP, and the second one is management of iris abnormalities. After that, we will have a short discussion for 2 to 3 minutes. We'll stick to the time. May I request to have the slides, please?
No, 12 minutes duration तो रख दो ना.
Pardon?
12 minutes रख दो.
Yeah.
Present 2 within the 12 minutes.
Yes, within 12 minutes.
discuss.
We will finish. Yes.
12 minutes रखना.
Slides, please.
Duration 12 minutes रखो.
PPT वाला slides. का वीडियो है ना
उसमें
वीडियो है.
टाइमर लगा दो ना. हाँ, total 12 minutes रखो. We are, no, don't worry. Timer लगा रहा है सबकी. We are giving some importance.
हाँ, नहीं, of course. नहीं, मेरे तरफ से लेट हो गया वो. I never knew.
लोगों को सिखाने के लिए मुझे मालूम है ना.
नहीं. क्या हो गया?
12 minutes रखा है. 12 minutes आ जाना चाहिए प्रेजेंटेशन में. स्क्रीन पे प्रेजेंटेशन.
स्क्रीन पे ले लो ना.
प्रेजेंटेशन ले लो. थोड़ा जल्दी. वो ऑलरेडी वी आर वेस्टिंग.
असला की नाही. Okay, so we have some technical glitch. So with the permission of the panel, I'll keep the timer. Okay, I'll maintain it. Thank you, sir. You can start, sir, please. No, I'll take the timer, sir.
अच्छा इसका सपोर्ट नहीं कर रहा है. It is not the timer which is not.
Math support नहीं कर रहा.
क्यों?
No, math ऐसे में pendrive है.
Pendrive में I will have to. It will take time. Very heavy files.
नहीं math ऐसे में kind of the connector ଅଛି. Brother, connector अछि.
क्या हो गया बेटा?
ना मैथ सपोर्ट करना चाहिए ना. उसको लगा तो ना कनेक्टर है. अभी आया था ना.
इसका नहीं आया था, वो लोगो है.
अच्छा.
हेलो. सपोर्ट का कौन?
क्या बात है.
सपोर्ट कौन?
क्या हो रहा है? What is he saying?
He is saying that the Mac is not supporting. लेकिन आपका वीडियो तो ये
नहीं होगा ही नहीं ना फिर.
आपका इंजीनियर का साइज बहुत बड़ा है वीडियो का.
नहीं हो रहा है.
फाइल.
और एक बार लगा दो. दूसरा है वो भी लगा.
मेरे पास है. I'll give it.
मैक का अगर अडाप्टर नहीं रहेगा तो कैसे होगा?
और क्या?
आज के ज़माने में वो मोबाइल से फ्री होगा तो ना.
ये देखो लगा दो. भैया और एक बार ये लगा के देखो.
इसको देखो.
को समझता ही नहीं क्या?
हाँ अभी आया कुछ देर कुछ तो आया
हाँ डन 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 या
लूज वेरी गुड बड़ा लूज कनेक्शन এটা দেখো পুরোটা লুজ লুজ আসতে লাগবে
हाँ
ना ना आ रहा है ये कहीं लूज कनेक्शन हाँ पूरा लूज अभी देख ये ठीक है
हाँ करेक्ट
हाँ बस
अरे तुम लोगों के ना केबल्स वगैरह भी नहीं इतने
କ୍ୟାମେରା ନାହିଁ ରେ ଭାଇ କ୍ୟାମେରା ନୁହଁ ତ ଡେଫିଟ୍ରେ ଆସିଥିଲା ଲ୍ୟାପଟପ୍ରେ ଦେଇଥିଲି ଆଗକୁ ଆସିଥିଲା ହଁ ଆସିଥିଲା ଏବେ ଲୁଜ୍ ହେଉଛି ଯାହା ହେଉନି ଦୁଇଟା ଚେଞ୍ଜ କରିଥିଲି ନଉନି नहीं हो रहा वो सपोर्ट नहीं कर कनेक्टर को एचडीएमआई पोर्ट का सपोर्ट कर
केमिन होबा एबे या पूर्व मोर भी थिला मैं मना कली पेनड्राइव करिया पे और ए सर पेनड्राइव ही पेरन तांगर जो वीडियो सेते बड़ साइज पेनड्राइव ही पेरन पेनड्राइव जमाना रे हम केते आगु आसिलनी बाबू
नहीं रिस्टार्ट नहीं सबको फीड ही नहीं दे रहा है ना
टेक्निकल सपोर्ट भी है मुश्किल है
लूज होची कोन लूज होची कटी होची तुम्हारे जाओ किस कनेक्टर আছে না নো कनेक्टर
दिस इज नॉट गुड
No, that must be good. Actually, our system mustn't be taking. He must be presenting everywhere, na?
या
So our system may not.
our system is not taking
हमारा सिस्टम क्यों एक्सेप्ट नहीं कर रहा है ये तो
वही वो सही बात है.
वी शुड हैव दैट ना ये नहीं कर सकते कि
रिवाइज्ड वाली इसमें
Every time
ट्रांसफर
we
कर दो
ask them to get that. Sir, you have it.
नहीं नहीं आई विल हैव टू ट्रांसफर इट विल टेक
Take long
टाइम
टाइम लॉन्ग हो जाएगा तब तक करते रहे ना वो एकदम ट्राई आउट
तो काहे कि आपको जो सबବେଳେ ଅସୁବିଧା ହେଉଛି କାହିଁକି
आज नो यार all speakers will come they will present with
ବହୁତ maximum ଲୋକଙ୍କର Apple speaker
apple नहीं ରହିବ मोटा मोटा मात्र सेटा बना के हम स्मॉल प्रेजेंटेशन कर दे मैं आहुरी बहुत प्रेजेंटर आसीबो
बिना एप्पल के अभी होता ही नहीं है
exactly all the national international speakers they will present with apple only
असुनी
मैं भी तो कनेक्टर लगाया नहीं हो रहा आ रहा
हां असली असली
वेट करो
ये डोंट हैव आपके पास स्पेयर केबल भी नहीं है ये वाली इसमें केबल में ही प्रॉब्लम है लैपटॉप और इसमें प्रॉब्लम ही नहीं है
तो केबल में प्रॉब्लम
आपकी केबल
दूसरा उधर है
हाँ लगा
सेपरेट लगे ना
ना प्रॉब्लम ही नहीं आना चाहिए
टू डैश टू नहीं यार
नहीं आ रहा अच्छा एटा तुम जो एटा तुमरो
टूडा आ गया
ट्रांसफर कर लेता हूँ मैं फिर बैठ के उधर करना पड़ेगा ना सर इट विल टेक फ्यू मिनट्स वही हो जाएगा एक टॉक कर लेता हूँ मैं आइरिस abnormalities
ट्रांसफर करके
ଆସିଲେ କ'ଣ କରିବି କନେକ୍ଟର ଥିଲେ ସପୋର୍ଟ ତାଙ୍କର କରିବନି ମୁଁ କିଛି କରିପାରିବି ଆପଣ
इधर स्टेट का एआरसी कौन है? हु इज दिस स्टेट एआरसी?
ଆପଣ ଆଗରେ ନୂଆ କନେକ୍ଟର
हाँ शर्मिष्ठा सीएससी वी डोंट हैव वेर इज डॉक्टर शर्मिष्ठा कुछ ना चेक कर दो और क्या no no when AOS chairman scientific ARC is here and what the state वाला कर रहा है state level should be here हाँ उनका पूरा हाँ गार्लैंड no 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 ARC only state ARC not president vice president शर्मिष्ठा मैडम आपने ARC चेयरमैन AOS का बुलाया और कोई फैसिलिटेट ही नहीं कर रहा है ही केम लेट बाय 12 minutes and now 4 minutes this thing what could be the reason madam are you against Dr. Prashant Bhawankole?
Not at all sir because I'm not against that's why 3 talks were given back to back sir.
Why 3 talks were given? See some distractors may be there they must have done this at least 1 or 2 supporters should be there for him for all the 3 talks yes. No, no, no. I am speaking for the AWS, not the chairman. AWS. Yeah. Now I am coming to the state level. Past president. That's why I am talking about here. AWS. A representative has come and no one is attending him, and a lot of halla is going on. He could not reach on time. First of all. आपने फूल किया या फूल किया? अब वो यही तो प्रॉब्लम है ना जाके वो बोलेगा उधर हम उड़ीसा में गया और मुझे फूल डाला लेकिन फूल किया यही तो प्रॉब्लम है ना बड़ा बड़ा लोगों को क्यों बुलाते हैं उसका फाइल साइज बहुत बड़ा होता है ये प्रॉब्लम है ना 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 आपको हमने 30 minutes दिया 30 minutes whole 30 minutes is for you only actually you should entertain I'm taking the time yeah वो आप स्टेट के लिए क्या पैकेज लाया प्रशांत पैकेज क्या लाया स्टेट के लिए विदाउट पैकेज वही यू हैव No. I'm asking what we are getting from the center. We require some funds for the state. We are SATAS funds. Hey, Prashant, are you sanctioning any amount for this session while conducting this in the state? CSC is giving. No. We have brought the whole AWS here actually. Certainly. How much? No. वो तो follow up होगा. You are asking for a danger actually. I will photocopy and then. No. That application will circulate all India, and there will be a movement against ARC. Ligue. ओडिशा बल्लो करती लेकिन जो लोग हैं वो बल्लो नहीं कर वो खूब बल्लो Let's now the focus shifted here now. Let us see. Hope it works. भैया जल्दी ओपन करो. Right now we are ready. वीआर सर्जन के लिए पैर भी इम्पोर्टेंट है मैडम. No, I think you speak something which is general interest to the patient.
कौन सा वाला सर बोला?
वो वाला यार 10 बार क्यों बोल रहा है? You should be smart यार. उड़ीसा के people
वो तो सही है, वो सपोर्ट नहीं कर रहा है. देखिए जैसा लग रहा है उसी में नहीं कर रहा है.
क्यों नहीं हो रहा?
मेरे को
What could be the reason?
He doesn't know यार
It
basically.
doesn't. Yeah, they do not. हाँ, वो तो प्रॉब्लम. तुम्हारा इसमें अगर नहीं होता तो फिर मुश्किल है भाई.
दोनों लैपटॉप में वो
अरे तो पेन ड्राइव से मटेरियल नहीं होगा, कैसे नहीं होगा यार? इतना तो आप लोगों को आना
ट्रांसफर
चाहिए.
डेस्कटॉप पे ट्रांसफर करो वो मटेरियल. ये वाला पूरा ट्रांसफर करो उधर.
कॉपी लो.
कॉपी हाँ. डेस्कटॉप लो. नो हाँ. पेस्ट हो रहा है ना. वेट करो. He will get full time actually. We are very very sorry, sir.
आपके एरिया में ना के.
एक दिन का आपका लैपटॉप कंसोल में दे सकते हैं ना? आपका लैपटॉप वहाँ पे दे सकते हैं.
हाँ दे सकते हैं ना.
ना ना ये तो होने दो. ना 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 हो रहा है. अच्छा है. It will take 1 minute. That's it. हाँ हो गया भाई. 30% हो गया कॉपी. Prashant, 70% is over. It will be ready. %80 हो गया. भैया इधर आ जाओ. ये रेडी है. 90 आ गया. ये आ गया. देखो ये इतना भी अक्ल नहीं है तो क्या कर सकते हैं. 95% हो गया ना. कॉपी करके ये ओपन करो. अभी भी नहीं होता तो फिर देन वी विल कट योर पेमेंट. है ना. वो नहीं है यार ऐसा. ये इंटरनेशनल फैकल्टी है. फेमस है. हाँ बोलना पड़ेगा ना. दे डोंट अंडरस्टैंड. वी आर फ्रेंड्स.
अब क्या हो रहा है?
ओपन नहीं हो रहा है.
अभी क्यों नहीं होगा? अभी तुम्हारा डेस्कटॉप पे है. यस नो वायरस. ठीक है. ये क्लोज करो. सब क्लोज करके तुम्हारा इसमें हाँ अभी ओपन करो.
ये क्लोज करो.
ये भी क्लोज करो. इसको हाँ अभी ओपन करो. पावर पॉइंट फेल टू. नो प्रॉब्लम. डू यू वांट टू सेव मोड? नो 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 राइट, अभी ओपन हो जाएगा. यस यस बोलो. No, open हो रहा है, but it's very big. हाँ, मैकबुक है तो उसमें ही एक बार कॉपी करो, ये वाला ले लो, ये तो खोल सकते हैं ना, ये निकाल सकते हैं, उधर कॉपी करो, तुम्हारे इसमें ओपन करेंगे. हाँ, वो कनेक्ट करके देखो. नो वो बहुत स्लोली ओपन ये हो रहा है इधर. सी इट इज कमिंग नो, वो पहले ही करेक्ट कर रहा है पूरा.
बुक में लॉक
उसका मैकबुक में
और सबका मैकबुक से वो जो रेड
वो पहले ना तो रीड करो, देन वी विल. मुझे मना किया ना, मैं इसलिए मेरा जो प्रेजेंटेशन है मैंने पेन ड्राइव में कर दिया, बट मेरा छोटा था ना. इधर देखो तो बाबू, इधर देखो मोर प्रेजेंटेशन. ये बहुत स्लोली हो रहा है, देखा ना.
It's a very heavy file. I know.
हाँ, इसलिए. Because she promised me 5% of her earnings fellowship के टाइम पे भूल गई. अरे भाई पेन ड्राइव दे रहा मुझे साइज बोला जो मेरा कॉपी वाला 3 GB आउटस्टैंडिंग होने वो बात जाएगी इधर से 5% only ना 95% किसी ने तो गवर्नमेंट ले. તમે કોઈ भी मैकबुक रे एनिकेशन में कर देता तो इन्हीं मैकबुक बिल कर रहे हैं खाली. तुम्हारा मैकबुक अच्छी की वो मैकबुक आने के चले की देखा. ये इतना टीच करते हैं तो ये 5% 95% इज देयर सर ना. ऑफ कोर्स यू कैन रिड्यूस द टैक्स आल्सो, नो प्रॉब्लम. मैं कोई सिस्टम के चेंज करके अधा लोग मैकबुक यूज करछन. ठीक बात नहीं है, इट्स नॉट गुड. ये तो कभी ओपन नहीं होगा. मैकबुक से गोटे आनी रखिए ये सिस्टम रखिंट गोटे मैकबुक बिल्कुल हो ना कि आम सब ट्राए कर मैकबुक मैंने देखो सब नेशनल मैकबुक हो ना कनेक्ट होनी मो कनेक्ट भी होनी मो लैपटॉप होनी सार लैपटॉप होनी ये मोर पर्सनल कनेक्ट तुम कनेक्ट लगा
क्या फर्क पड़ेगा बेटा, ये तेरा कनेक्टर में प्रॉब्लम है.
रिपोर्ट चेक करते लैपटॉप चेक करते हो नहीं.
और वो आया क्या?
मोटा तो ट्राई पे सार लैपटॉप खोलने में मुझे सारे कोड खोल दो.
आएगा आएगा कहीं बाहर गया.
आ रहा है या नहीं आ रहा है? तुम्हारा कॉपी कर दिया इसमें उसका प्रेजेंटेशन?
पेंडर सारंग प्रशांत सर
प्रशांत पेन ड्राइव दे दो उधर.
they have not done the dry run for the mark.
नो मैक करना चाहिए. दिस इज इम्पोर्टेंट. ये कॉन्फ्रेंस ये स्टेट लेवल कॉन्फ्रेंस है भाई. यू शुड नॉट टेक इट लाइट.
এটা দেখি লগে কি দেখা হতো
इनको ही
देखुची से करिक देखु
प्रॉब्लम हो रहा है ना?
प्रॉब्लम हो रहा है.
इट इज देयर प्रॉब्लम. इट इज नॉट द सिस्टम प्रॉब्लम. इसमें भी तो आना चाहिए यार. ये दूसरा मैक है. वो देखो उधर ही रह गया. वो क्या हो रहा है देखो. रिपेयर. हाँ फिर से
क्या पीपीटी ओपन हो जी सही.
ना 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 वो रिफ्रेश करो एंड ओपन करो इसको. वो उनका प्रेजेंटेशन है. हाँ ना 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 प्रेजेंटेशन इधर है. ना ना हम लोग कॉपी कर दिया इधर डेस्कटॉप पे. वो ओपन होना चाहिए.
ये रिपेयर में
हाँ या
ये रिपेयर में
वो रिपेयर.
What is it telling?
लास्ट टाइम प्रॉब्लम हुआ. रिपेयर करना नहीं करना. रिपेयर कभी भी नहीं. प्रॉब्लम है.
What is it is showing?
इट्स कंपैटिबिलिटी नहीं है इससे.
Oh,
दे वांटेड. हाँ दे सिस्टम सेइंग शैल वी रिपेयर. रिपेयर करो वो भी अभी तुम्हारा प्रेजेंटेशन इधर आ रहा है, तुम्हारा और एक बार मोटे चेक कर दो बाबू भैया, इधर इनका सिस्टम में उनका प्रेजेंटेशन करो, इनका नहीं, ठीक है चलो लोग वो चलता है एटलीस्ट अदर प्रेजेंटेशन, ना अदर प्रेजेंटेशन नॉट अ प्रॉब्लम, दैट इज व्हाट आई एम सेइंग, राइट। अच्छा एक मिनट ऐसा आगे ऐसा आई थिंक ये ना तुम्हारा अदर प्रेजेंटेशन देखो इधर कनेक्ट एक मिनट रो इधर मतलब खोली पारे कौन ये दीटा ना ठीक है मोर मु देखी दूसरी रो एबे गोटे मोटे देखो चेक करो एटा मोटे पीपीटी खोलची एटा देखो
ये एआरसी का कमाल है, एआरसी का कमाल विदाउट परमिशन।
अच्छा नहीं मोटे चेक करो मोर सिस्टम आस्ट्रेलिया ने इसका चेक कर चेंज किछ नहीं, एटा बढ़िया है रिजोल्यूशन चेंज किछ करना मु पर काली एटा हमर प्रेजेंट करि के से को जगह रे ठीक है तुम करो 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 देखो देखो अन्य सेटिंग मु जाने नहीं सेटिंग जाई एटा तुम एबे जोटा खोलु तुम करू न
सेटिंग डाला हम सारे रेजुलेशन में तो मिस
इसका इसमें आ रहा है इसको लगा दो
अब इसका क्या है?
बाद में ये चेक करना ऊपर वो आदत टाइम हो गया लेकिन I'm thinking कि कब क्या और आ जाएगी सबको बदनाम करके मैं नहीं भेज सकता तो दोस्त है तो वो कुछ भी बोलो तो you will accept not everyone no हाँ ये इसका 10 होता है ये प्रॉब्लम है जो भी ना काफी नहीं मारता जो भी अच्छा है वो इसके पास आ जाता है बस ये काफी भी नहीं किया देखा ये कुछ
नहीं he was sitting by my side sir मैंने उनके वहाँ से प्ले किया it was not playing
alright yes we will have your presentation yes no we will have your presentation yes good very good where is microphone see microphone
नहीं ये अरे ये तो मुंह नहीं हो रहा
या हाँ नहीं आ रहा है
अब मुंह नहीं हो रहा ना बेटा हाँ
ये
आना चाहिए ना बेटा
उधर नहीं आ रहा हाँ उधर आया अभी उधर आया
हाँ अभी आया
आ गया हाँ नेक्स्ट करो वीडियो
हाँ
हाँ आया बस I think with great difficulty finally Prashant has succeeded
अरे क्या हो गया
फिर से क्या तुमने क्या किया मेरा होता तो
नेक्स्ट मालो आसुजिबा
या राइट आ रहा है थोड़ा थोड़ा हाँ be careful and then handle it very carefully. Yes. Anyhow, finally we are ready. Let us Bhrutendu.
ये
You need
निकाल
to
लेते
moderate, I
ये
think.
ये वाला
Yeah,
निकाल
Chitto,
लो दिखता नहीं
please
है
come. With lot of difficulty, but Madam CSC, we need to be ready for tomorrow's MAC presentations. Yes, thank you. Right, Prashant.
Okay.
We are very, very sorry.
No, it's
yeah, you can present.
Sure.
And you can take any time you
No.
One presentation at least, let it finish.
I will tell you.
Yes. No.
Okay, fine. Chalo.
No.
So good afternoon, and finally, shall I, sir? Okay.
Please.
अब क्या हो गया बेटा? ठीक है अभी कुछ नहीं छेड़खानी करो suffices no it's quite enough okay friends good afternoon and let me at this outset thank Odisha State Ophthalmological Society for this wonderful invite. After a lot of hiccups, it began right from the place when I started from Bhubaneswar. It took me almost 1.5 hours. My driver promised me it will be 20 minutes. And I reached 10 minutes late, and another 50 minutes we had this technical snag. So I would be only curtailing to one talk which is very close to my heart. I would be speaking about iris abnormalities. Okay. So whenever we have an iris trauma, either in the form of an iatrogenic or it is because of a trauma induced on the field, there is an iris abnormality, there is a damage to the iris tissue, and it can lead to causing a glare, visual disturbances, photophobia, and most importantly even to the loss of cosmesis. So this is a video of about few cases where we have repaired an iris, where we are trying to tell you that beyond IOL placement, beyond doing a vitreoretinal procedure, the importance of creating an iris pupillary diaphragm and how it helps and how any one of us can do it. So this is a 10 years old boy who had a trauma and who had a 180-degree disinsertion of iris root. He also had traumatic cataract. He was referred to us for cataract management. So how do I do? Yes, of course, everyone can do it. It's a very soft cataract, not a subluxated cataract. Job was easy. So here the video will begin. Initial part of the video is how to preserve this iris tissue coming into the active port. So how do we go? So first foremost thing is to preserve this iris tissue, and for this you have to get this floppy iris away from the thing. And once you do it, how can I stop it here? Okay, once I do it, I have put a lens, and now I am going to do an 180-degree, means iris root insertion. So this goes a tenoprolene suture through the scleral tunnel, and here I am hooking over there. After that, I realized that the iris is big towards 9 o'clock meridian, so I decide to do an additional 4th row knot pupilloplasty. And here I do a 4th row knot pupilloplasty. Here are the 4 knots, and they are pulled externally and then cut. And you can see the realization that I have done. This was the pre-op photograph of this patient, and this is the post-op photograph of the same patient, where not only we have rehabilitated this particular patient with a good pseudophacos, but also given him a good cosmesis, also a circular pupil. Okay. Now coming to the case number 2, this was a case which was repaired elsewhere. He had a corneal scar, and you can see which was repaired elsewhere. He has a traumatic cataract, and this is the iris tissue which is rolled over here. But this iris tissue, in fact, would suffice only up to this. So intraoperatively, after having done a cataract surgery, having done after I did lensectomy, vitrectomy, and IOL placement, this video will begin from there. So first step after doing is to assess how much is the iris tissue, and I realized the iris tissue is just sufficient enough to reach up to 7 o'clock. So first my job is to do an anchoring of the iris available over at 7 o'clock. Same thing I do it again at 5 o'clock to decrease the iridodialysis area. Now I need to approximate this iris tissue and compensate whatever the iris tissue loss was there. So I do a fourth row knot pupilloplasty. Once I do a fourth row knot pupilloplasty, you can see a big defect over here. So now I do an anchoring of this particular thing, iris tissue over here. Here the iris tissue was quite live, very not very devitalized, and so we could manage, and you can see this is the end result of this patient. Almost a circular pupil with a good pupillary diaphragm. So two procedures we did, iris root anchoring as well as fourth row knot pupilloplasty, helping us in creating, and most importantly, unlike other case, here there was a deficiency of iris tissue which we compensated by creating some iridodialysis and leaving iridodialysis and moving the iris diaphragm over there. Now this is almost a 1 month later post-op photograph of the same patient. Now this is another patient who had a traumatic dislocation of a cataract. You can see the iris all bundled over here with a vitreous hemorrhage. On a B scan, we thought it is a funneling of the retinal detachment. The challenge in this cases is whenever we do vitreous surgery, we use some tamponade to put back the retina, either in the form of a silicone oil or in the form of a gas. The moment we use an oil or a gas, the commonest complication is corneal decompensation and secondary glaucoma. Why? Because of the migration or pushing of the tamponade, the iris diaphragm towards the cornea, leading to decompensation and secondary glaucoma. And so in such cases, what do we do if we do not have an iris tissue? We use the tenoprolene suture as a knot, but this does not really act that efficiently. So here I have an iris tissue which is slightly devitalized, and I would like to do beyond lensectomy, vitrectomy and scleral fixation of IOL. I am going to do an iris repair, and again here the video starts. You can see first how I am trying to preserve. Here most important thing while you are doing a vitrectomy or lensectomy is to stay away from the iris tissue, which is very floppy, which can be drawn into your iris cutter anytime. After I am isolating the lens with lens from the vitreous which was attached all across the section. It is a repair die. Okay. So vitrectomy was done. Luckily for us, this particular patient had a attached retina. So now here I am doing with the fragmentome the lensectomy. I inspect the periphery. Luckily for me, it is okay. So I do a 360-degree barrage as a prophylaxis. And after having done that, now I am doing a base excision under direct microscopic visualization. Okay. Once this is done, everything is ascertained that the retina is in place. My job starts of an iris repair. I cannot forward the video over here somehow. I don't know how to forward in this particular system. Here I am assessing the iris, and luckily once I pull this iris, I realize that it's a 270 degrees iris root disinsertion. But this job was relatively easy for me. I had to anchor it at 3 or 4 o'clock meridians, and precisely that is what we do. A tenoprolene suture goes through the scleral tunnel. A railroading technique is used, and here comes the suture. And once I have the first anchoring done at 1:30 o'clock meridian, I realize that my job is easy. And you can see that the iris is getting stretched. Here I pull it out, and once I do this, you can see the relative construction of pupillary diaphragm. Same procedure is now repeated at 2 or 3 meridians, and I will just move to the next slide for want of time because it's a repetition, and this is exactly what we did. This is about a month later. So it's such a bad case where we did lensectomy, vitrectomy, we did a tamponade, later on we did a scleral fixation of IOL, but importantly we created an iris pupillary diaphragm for this young boy, which is equally important in such cases. Now this is case number 4. This is before repair, a traumatic hyperemia. We could see a scleral tear here, and we did repair. And after repair we realized that the iris tissue is disinserted over here. And so now comes the second step that is done about 10 to 12 days after the primary repair surgery is done. So this is the case where we are doing a vitrectomy. Again, I have to create an iris pupillary diaphragm, and I realize this iris tissue is being pulled before I do the vitreous surgery so that it doesn't come into my active ports. And here again, luckily for us, the retina was okay. Posterior segment injury beyond vitreous hemorrhage was not there. So we complete the vitrectomy, we do a barrage, and after that my assessment of the iris tissue happens. I thought this is a iridodialysis over here, but in fact this was disinsertion of the iris. Once you assess how much is the iris tissue, my job here was to anchor it again. You can realize this big is the disinsertion. The challenge here was a scleral tear which was repaired, but still creating a small superficial scleral flap allowed us to anchor that iris over there. And I would just, so anchoring is done at 1:30 o'clock. Then again at 2 or 3 meridians we did it, and you can see this is the end result of this particular patient post-op day 5. So this is how we can repair and prevent this eye. Now this is interesting case. This is a congenital cataract. I was doing a pediatric cataract. This is a 2-year-old boy who came to us for cataract surgery. So cataract surgery in a pediatric case is not very difficult for us. It's just a, just phacoaspiration. You do a good rhexis and you have to do a phacoaspiration and you can put the lens in the back. And this is what happens even at a stage when you have a 25 years of experience in vitreoretina and doing cataract surgeries. So this cataract surgery, this is being fast forwarded. It was very relatively easy. And once I have done this, now when I am trying to put the 3-piece lens in the bag, you can see that what I have done. I have not only torn the iris sphincter, but also disinsertion of this iris. It really, this is what happens once you relax in the last minute of your surgery. And this gave me a serious complex. I was really guilty, feeling guilty. I thought this 3-year-old guy cannot have a sector iridectomy to live his life with. So I did a 4th-row knot pupilloplasty and an iris root anchoring. So first job is to do a 4th-row knot pupilloplasty in this particular case. And I could approximate and create a pupillary diaphragm. Then I had to pull the iris diaphragm, which was pulled down by doing an iris root anchoring. That is, again, remember, tenoprolene suture has to go through a scleral tunnel, and here it is knotted. And this is the end result. So I could at least reduce my guilt in this particular pediatric case. I could give him a pupil and he could have some pupillary reaction, and the amount of glare and all that could be cut down. And this is about few months later when you can see a posterior capsular opacification and near normal size pupil. Now this is another case. This was status post lensectomy, vitrectomy, sector iridectomy done for corneal opacity. Interesting case, you look, this is sector iridectomy. So I do not have any iris tissue, almost 180 degrees. Okay. Plus this is a corneal scar which is causing an irregular astigmatism for this. So the concept given by Professor Amar Agrawal is to how to bypass this opacity, and if you can bring down the size of the pupil, you can bring down upon the glare and the quality of the vision. And so this video would again begin, this video somehow is missing, I don't know, it didn't copy. So we did a repair, and this is the post-op result of this. You will realize and you will point out, doctor, why is there such a big iridodialysis over here? Why? Basically because the peripheral lack of iris tissue is never going to cause diplopia. So I had to bypass this. So I had to accept a iridodialysis. Means what I did is I intentionally created an iridodialysis in available iris tissue to pull this iris over here and create a pupillary diaphragm and to have a central pupillary visually access. I would just show through it. Another interesting case similarly. Post corneal tear repaired, lens with silicone oil done elsewhere. Now this patient, you can see, has a 6 diopter astigmatism because of that corneal scar. Now my job was to do a scleral fixation of IOL along and try to help him out as best refractively as possible. So this is the post-op photograph. Again, this video has not copied. I'm sorry. This video is missing. Yes. Okay. These are few of the videos which are missing. I'm really sorry for that. Those were some interesting things, why you do an iatrogenic iridodialysis. Means what happens if you have only 180 degrees iris. If you have to compensate for this, you have to create a space. So you create an iridodialysis in this quadrant and bring this iris tissue, approximate it and create a pupillary diaphragm. That's what I wanted to show in these 2 last videos. And this... नहीं हो रहा है नहीं हो रहा है इसमें तो नहीं आया है. So this was a beautiful video where we couldn't show you the video that unfortunately didn't copy. And this is another case where we do what is called a aniridia with a cataract. Commonest reason for aniridia, second commonest reason for poor visual. The commonest reason for poor vision in a case of aniridia is a foveal hypoplasia. And second common reason is the photophobia, which makes this patient's life more unbearable. So what we do is we do an aniridia IOL. What we do differently is aniridia IOLs come as a single piece IOL. They are rigid IOLs, they are customized IOLs. So what we do is, instead of anchoring them with the help of a tenoprolene suture, which leads to pseudo-phacodonesis, we do a scleral fixation by externalizing the haptics of this lens and do a what is called a glued IOL technique with this. This gives you a more steady type of a lens. And this is one of the post-op picture of the same patient where we have done a scleral fix, an iridia IOL along with, by doing a scleral fixation. And this is about few months later. So friends, why do we need to repair? Because if it is a posterior segment injury, you need to compartmentalize between an anterior chamber and a posterior chamber, especially when you are having a vitreoretinal procedure, because tamponade can cause glaucoma and corneal decompensation. Second important thing is you can create an iris tissue which can be used for support of IOL for people who are not doing scleral fixation. And more importantly, if you have an iris pupillary diaphragm, it gives you less glare, less visual disturbances, less photophobia, and that means it translates to better quality of vision. And most importantly, this trauma and these are more often associated with younger age group. And of course, remember the beauty of the eyes remain in the pupil, and it is because of the iris. So giving back the cosmesis to these young men is equally important. Okay, so my challenge to younger friends over here is, patients come to you for simple cataract surgery and vision, and they would be happy even by giving them a simple scleral fixation of a lens or doing a PCIOL or doing a retinal procedure. But you as a retina surgeon or you as a surgeon has to do more what you can do. So iris repair is equally important, and so never settle for less. Do repair it and patients will be thankful to you throughout life. Thank you.
You have presented very well.
Thank you.
He never settled for the quality.
Okay. Very excellent talk as usual.
We are very
So,
sorry that a little bit glitch, but
yes, we apologize for that. And with permission, can we take only one question? Only one, sir.
Yeah.
Pramod Sharma, sir.
Large iris. It depends. No, I will tell you. There are two situations, sir. If there is no iris tissue loss, the job is relatively easy. When it is fresh, viable iris tissue diaphragm. And that is why it should be referred typically before 1 month after injury. If the iris tissue becomes devitalized, the iris tissue is not that vascular, then these challenges come. One is, in spite of having an iris tissue, this iris tissue becomes friable. Wherever you are trying to do, it becomes frail, and wherever you put a suture, it causes more opening. So this is a challenge. So you have to be very careful. You have to be really gingerly you have to do and see how much tightening is appropriate enough. Now the third challenge is when there is an iris tissue loss. So in these cases, what you are supposed to do is to create an iridodialysis. Remember, the IOL is going to be, whichever IOL you put, is going to have an optic size of 5.5 to 6 millimeter. Beyond that, it is going to be an aphakic zone. Aphakic zone, even if you remove the iris tissue, is unlikely to cause a diplopia unless that patient is true to, type 1 personality, where he can see a ghost image through the aphakic zone as well. So you have to cover the optic zone as much adequately and make it as small as 3 to 4 millimeter. It gives you the best quality of vision. That's what we mean.
Thank you, sir. Very aptly told. Murli, sir, what's...
Yeah, that goes unsaid because you have to sacrifice the lens. You have to sacrifice the lens. Pardon? Yeah.
So same
After
thing. So
that
point is well taken. It should be done in a pseudophakic eye. So may I request Dr. Subal Kishore Kaur sir to please felicitate Dr. Prashant Bavankule sir, who has taken all the pain in traveling to Odisha, and excellent talk. Please give him a very big hand, Dr. Prashant Bavankule sir.
yes, very good.
Yeah.
Sir, No, no, ye do.
Thank you again, sir. So with this, may I invite Dr. S.T. Mullidhar sir and Dr. Sangamitra Kanungo madam, if they are there. They are the panelists. Sangamitra madam is not there. Mulli sir, Subalkar sir, please stay here. One more memento we have to give. Dr. Mulli sir. Now done. Yeah, immediately. Thank you everyone, and with this we come to the conclusion of this session and we will move to the live surgery session very immediately. May I request Dr. Sweta is there. Dr. Sweta Dhiman, please. She is the moderator of the live surgery session. Please come forward, Dr. Sweta.
Good morning, everyone. Am I audible?
Yes, ma'am, you're audible.
Yes, you are audible. Madam,
So, recording in progress. So we'll be starting the live retina surgery from JPM Rotary Eye Hospital. So the first case will be operated upon by Dr. G.N. Rao, sir. The first case is a case of advanced PDR with vitreous hemorrhage. So over to sir now.
Okay, Dr. Anuja, thank you. So we'll be moving to the surgery. Before that, Dr. Sweta wants to announce the panel name and the chairman, please.
So we welcome our panelists, Dr. Sabyasachi Patnaik, sir, Dr. Pramod Kumar Sharma, sir, Dr. Subhabrata Parida, ma'am, Dr. Chitranjan Mishra, sir. Over to you, ma'am.
Good afternoon, everyone. My teachers, colleagues. Am I audible?
Yes, you're audible.
Yes. Shall we start?
Yes, yes.
So this is a case of advanced PDR, what Dr. Anuja has told. This is a case of advanced PDR with vitreous hemorrhage. I could see some few membranes were there over the disc, proliferative membranes. So here we'll go with vitrectomy. So before actually you plan for surgery, ideally one should have the knowledge of actually posterior vitreous, either by ultrasonic examination or by OCT nowadays, because the media is clear, something you are seeing, but it's utmost important in diabetic cases because of innocuous PVD. Most of the time, it's very much important to assess the posterior vitreous before you start diabetic cases. So the insertion is, ideally I designed this, in fact I presented in 2023 VRSI. It's a 3-step insertion. Once, next trocar I will show. So this way you can prevent post-operative leakage most of the time. So checking cannula is very important. Even though vitreous hemorrhage will be there, the beginners, they may not see the cannula properly. One should have the, suppose if you are unable to see properly, then at least take the help of this light and through the light. So see the cannula which is inside the vitreous cavity. So 4 millimeter from the limbus. So here one is, this is up to the shoulder of the blade, tip of the blade, first insertion. Second will be up to the cannula length, the ending of the cannula. Then third is again up to here. This is the way, suppose if you will create 3-step, then that makes actually almost a complete no leakage you will find. This is up to the shoulder. Then turn it like this, then like this. This way, This gives a better, no leaky wound. Sit down, nahi, get the officer. Light. Okay. Yes. So we are operating on, we are taking the machine is Constellation, which is the dual system, both phaco and vitrectomy. And so we using the hypervit 20,000 cut rate. कौन है लगे रे ये फॉग ही होची ना कौन देखा कहीं क्या ना चल कर लो
Yeah. Sir, you are using the resight system for the wide angle viewing, right?
Yes, yes.
Yes, sir. So in between, one request to all our audience to please keep the mobile in the silent mode. This is a request.
अरे फोकस कोडी अछि म बहुत असुविधा होछि मते एटा फुट स्विच सिस्टम ता अरे फोकस ता कोठी अछि रे बाबा मते असुविधा होछि फोकस ता करियो मोर सिस्टम अलग है अंकर सिस्टम अरे फोकस कोडी अछि रे बाबा अप डाउन होछि रे जूम टा ही होछि ना फोकस होनी बाबरे इठु कल में फोकस यार फुट स्विच टा को करियार थिला देख मार्किंग पळुज मन इच्छा फुट स्विच ता मार्जिन थिला सिन कलुन रे अब के So this is okay, ये fog होची अब टिके फोकस टा बाबरे फोकस ऊपर कर ना हां ऊपर को अप ओके गुड आउट ही करे so ideal always wise to clear the opaque what are the vitreous behind the lens before you go into the core and the cutter what we are using is hypervit as I told this is the updated or the new generation vitrector of Alcon hypervit which is having the 20,000 cut rate and almost no duty cycle because the port remains almost closed most of the time the cut rate is so high it actually sucks very fast and it finishes your job very quickly without having so much of trouble into the or putting traction over the retina 650 रखी बा 650 रखे vacuum no 650 रखे ideally the vacuum I use is 650 always the maximum vacuum because it depends upon because when you are using hypervit in the beginners better to keep lower vacuum because sometimes this is what see the choroid comes because of high suction sometimes the choroidal folds will be seen so better to keep a lower vacuum and operate for the safety concern if you are good enough you are a good surgeon then it's up to you otherwise better to keep little lower vacuum and cut rate is 650 always I keep, 650 the vacuum. Cut rate is constant 20,000. Ye dello.
Sir, as we can see, the surgery is going very fine, and you have already told about the cut rate and the vacuum. Can you please tell about the IOP setting, what you are having now? Because maybe we are anticipating some hemorrhage.
IOP is actually 36.
Okay.
Normally, suppose if you are using high vacuum, then in diabetic cases, always better to keep 30, 40 within, because diabetic cases, the perfusion pressure to the optic nerve as such remains little compromised, and if you keep higher, sometimes it bleeds, then you have to keep even 60, 80 you can keep, that is no issue, but otherwise better to keep at around 40, 30 to 40 is way.
And now, did you change the lens now, sir? The high mag lens?
Focus kalo.
The
Pere foot switch re focus nahi ki ma. Ye. How to focus kalo? Nahi ho ni ma. Focus karo. How to focus kar ma? Retina kare. अरे तू आसवा गुरु चेक करियार थिला तते फुट स्विच ता कोन दरकार आ टिके फुट स्विच करे क्लैरिटी नाही बिल्कुल ए जो ये डा फोकस करो नाही म फोकस होने ऊपर आ ये करे अब मोर फुट स्विच ता काई कोलुन इडियट.
So as you can see over here, the surgeon is nicely doing, he has already done the core vitrectomy. Now whatever the pre-retinal hemorrhage is there, with the alternate vacuum on mode, is removing the hemorrhage from the pre-retinal space. We can see over here, surface of the retina, yes. That PVD which is attached to the stump, that disc part, that stump, that will be trimmed, almost trimmed now, and you will be removing it also. So as we all know, he is working just near the macula, so it's a very crucial step.
So good afternoon, this is Dr. Sangamitra. Sir, would you like to use a backflush in such cases as you are going very close to the macular area?
What?
Would you like to use a backflush?
Yes, I will use. You rightly mentioned I will use backflush. Foot switch.
So as we are discussing over here, backflush is another technique, and sometimes you use the 1 cc saline also. Just take saline in 1 cc and inject it over there, that will be clear. Or sometimes the flute needle itself, just take it, keep it over there, that blood gets sucked. These are the different methods that is described, and sir is comfortably doing with the vacuum on mode.
So what I do is actually I just flush it, not black flush.
Yeah,
like
this is.
I do mostly.
Yeah.
This is a very good actually technique of just flushing it.
Yeah.
So that the peritoneal there is no blood will be clearly dislodged from the, because they will be sticking to the retina. Once you will do this, everything will be cleaned properly from the retinal surface. Then you can suck it out.
And one precaution is just check it. It should not be blocked thing, and it comes in a jet to injure the retina, just for the beginners. While injecting, before that we should check it that is there a free flow.
Not flush on the macular area, because sometimes you tend to flush it very hard and it might injure the fovea.
Yeah, exactly. So you should do it away from the arcade.
Yeah, clean, nice.
May I request the assisting nurse to please focus a bit.
Retina go. ନାଇଁ actually ନା ଆଙ୍କର ଫୁଟ୍ ସୁଇଚ୍ ଟା କ'ଣ adjust କରିଛି ନା ମୁଁ ଜାଣିପାରୁନି ଫୋକସ୍ ହଉନି ଫୋକସ୍ ଟା ଫୁଟ୍ ସୁଇଚ୍ ରେ ହଉନି increase 36 टा बड़ा 60 करे
So now sir is increasing the IOP.
To how much, madam? 60?
Yeah, to 60.
Okay.
So another method is you can just put your cutter over the bleeding area for some time. Sometimes that also helps.
Mechanical compression kind of thing.
peripheral lens कर এটা lens फोकस करे ଆଉ ଟିକେ ଉପରକୁ no need
Sometimes when there is blood in the peripheral part, so probably in those cases you have to clear it off because sometimes post-operative
right
this one vitreous halo in the same.
idiots दे लेजर दे
As we can see, the retina is very nicely seen over, and sir is going to do laser probably. Sir, one question to you now. This 20,000 cataract, the USP or the advantage you told, there is no traction or less traction. Apart from that, anything else, sir, in comparison to the conventional 5,000 or 10,000 cataracts? Cutter?
Quickly, relatively quickly you can remove the vitreous. That is the one advantage, major advantage. It removes the vitreous efficiently without causing any traction. Very minimal traction over the retina.
Okay.
Okay, laser. Idaku switch. There. Comma.
So as we can see, there is some grade 3 burns. So sir is asking to decrease the power of the laser so that the intensity is little less. Yes. Sir, while the laser is going on, may I ask you one question that do you believe in sparing the vessels? Because some surgeons advocate that we should give in between the vessels only and we should not do just like arbitrary. Any of your thoughts?
Laser, the teaching of PRP is always avoid the great vessels. Major vessels should not be touched.
Okay.
That is very importantly. You cannot put randomly wherever the vessels are there.
And sir, what is the power of the laser now? 150 or 200? How much?
130, and this is ideally, you should see a off-white color burn, that is enough, good enough. You should not be tearing the retina.
Yes, sir.
It shouldn't be white, very white. Already this case is lasered previously, but I am filling the gaps in between.
Yes, sir. The skip areas are being filled, yes. And sir, do you advocate doing a indentation and extensive base dissection in these eyes with VH, or it's not needed?
Ideally, not needed. Suppose simply what Sangamitra rightly said, if the vitreous hemorrhage is there sticking to the peripheral vitreous, then better to remove, but not very mandatory, because if those heme content will be there inside the peripheral vitreous, sometimes it trickles down to the post-operative period and causes again vitreous, dispersed vitreous hemorrhage.
Okay.
That may be, otherwise no need. You can leave if there is no traction.
Okay.
Those little vitreous hemorrhage can be left as it is, because once you will go periphery, chance of injuring the retina is more.
Yeah,
So
correct.
better not to, when it's not needed, you should not go to the peripheral vitreous.
Okay. And as we could see, you did not use IVTA, the steroid to stain the vitreous. That's a regular practice?
That is very important actually question what you asked. In the beginning of I told that one should be very much perfectly analyzing the posterior hyaloid phase, because most of the time in diabetic cases, what is the innocuous vitreous,
Yeah.
the PVD,
Yeah.
which remains very abnormal, and falsely you may see that the splitted or the skytic vitreous, the entirely skytic vitreous, you may think that it is a complete PVD, but the posterior thin membrane will be sticking to the retina.
Yeah.
That may cause again contraction and cause again a needus for the new vessels to grow. So one should stain, if you doubt, stain the vitreous or the peripheral, very posterior part of the thin membrane which remains attached. That should be stained and removed better too. Otherwise, it will cause again problem.
Yes, sir. So in the continuation of this discussion, do you do the ILM peeling or like staining and ILM peeling just to ensure that we have got rid of all the vitreous being removed?
Yes.
Or
Not all cases actually, because when I see that if the macula is little epithelial membrane is already formed, or the macula is a little crumpled, or some tractions are connecting to the adjacent or the arcade, if the stumps are there, in those cases if we will see like some distortion of the macula will be there, or ectopia of the macula will be there, fovea, then in those cases I may consider removing the ILM. Otherwise, there is no necessity of actually randomly going and peeling ILM.
yeah, correct. So just for the sake of audience, as sir is telling rightly, there is no need to peel the ILM always, but there are again debates. Some surgeons feel that whenever I go inside, I always come up with the ILM. They claim that I ensure that vitreous is removed and any prevention, like the prevention of ERM in the future. But again, the flip side is that you may injure in the molar cells, foot plates over there. So that's why it's a personal, it's surgeon's discretion over there.
Okay.
And as we could see, you did not use the diathermy also. That also again ensures that there is no injury or the vascular compromise is not there.
Because if the bleeding is actually uncontrolled or the profuse, then it's better to use diathermy. Otherwise, not necessary to always diathermize, because diathermy itself causes necrosis and
yes,
may create even the post-operatively diathermic area may cause retinal tear formation and cause sometimes localized detachments also. So if it's not needed, when you are using also very little, or the judicious use of
Very
diathermy is
judicious
always
use of
important.
diathermy, correct.
Audience, any
Despite all
questions?
this good laser, despite all this good laser and everything,
Sir?
most of the time still we
Questions
see
from the panelists?
post-operatively the bleed.
Any questions from the panelists?
I should ask
Sardana?
Hello.
Yes.
Hello, sir, I'm Dr. Shweta Patro.
Yes, tell me, Sweta.
Sir, in peripheral membranes, you said you leave them. Like, is there any criteria ki this many membranes you can leave or anything, or you put a buckle or something you do for them?
Peripheral tractions in diabetic cases or what? You are
Yes, sir,
asking?
diabetic cases.
If the peripheral fibrosal membranes you are noticing, then better to address those.
Yeah,
By
sir.
if you are not necessary to put a buckle always, because the track depends upon the traction and the localized how the retina is. If
Okay.
the retina is flat, only the membrane which is there, then you can address that membrane by doing dissection, good dissection, and doing any cryo or the laser, whatever it is. Otherwise, if the retina is surrounding retina is detached,
Hmm.
then it's better to put a belt or a buckle, whatever it you feel like,
Okay.
support that. Or some tears are there adjacent.
Okay, sir. So one more thing, like there might be like thin vitreous sheet which you were telling.
Limbs. Yes, yes. Sorry, I could not hear you. Tell me.
Sir, there is a thin vitreous
Limbs.
sheet sometimes, like vitreosis cases. You go and
Yes, yes.
you go in and check for them always, or if the retina is attached, you tend to clear off everything, or in the periphery, it's okay to leave it.
As I said, actually, peripheral vitreous, if the simply peripheral vitreous is there, there is some amount of blood is sticking to that, no tractions, nothing, then it's better to leave.
Okay.
Otherwise, if your only thing is always the posterior vitreous surface, which is vitreous chisis, always you anticipate in diabetic cases, that has to be addressed. If the posterior vitreous, if you are seeing some membrane, you are leaving the sciatic posterior membrane as it is, then it may cause traction. And that will be, more or less, it will be connecting to the periphery also, most of the time. So better to check whether you have removed the complete vitreous or not over the retina. If you have removed completely, up to the equator also you have removed, leaving the peripheral, no need to address the peripheral vitreous. If you have actually, because you have disconnected the connection between peripheral and the posterior one.
Yeah, yes, sir.
Okay.
Yes,
In
sir.
that cases, there is nothing to worry about.
Okay. Sir, you stay in all cases with tricot?
No. Wherever, if I feel like actually I'm doubt in whether I have actually addressed the second membrane, what you call the
Yeah.
sciatic membrane, then in that cases only I will do staining. Otherwise, there is no. This is always I do check the periphery, but every time we have to check.
Okay.
If you are going into the vitreous cavity, check whether the peripheral retina is, you have caused any damage or not.
Okay.
If some holes you have created, then it has to be taken care with cryo or laser and giving tamponade.
Okay, sir. Thank you, sir.
Sir, the indentation is done by the assisting nurse or by you?
No, myself. I do use limbs, this one, the flat surface of limbs.
Okay.
And with that I indent and see.
Okay. So surgery, as we can see, very nicely done. So 3 cheers for the surgeon, also the assisting nurse and all the people there in the OT. So big hand for them, all the OT team over there.
नहीं फैक्स नहीं ये जूम किम जाओ जूम आउट the foot switch that one. Rasa tidak kan emang? No. In this case, there is no need because no active bleed is not there. No, I don't do. There is no need.
Sir,
Simply leaving this.
Even if saline closed, still no need of suture?
That is what I am checking. Sometimes this wound is not leaking, but this is leaking. So you have to put a suture.
Nice tips on proper cannula insertion.
এটা কোন 80 60 দে মা 60 দে can dello ye dab bad de Stop, stop. No need. ଟିକେ ଟିକେ ହଉଛି ଗୋଟେ ଦେ ହଁ ଦେ ଦେ
Yes, sir.
ହଁ 40 ହଁ ମୁଁ ସବୁବେଳେ ସେତିକି ରଖେ ଆଇ ଡୋଣ୍ଟ ବିକଜ ଅନନେସେସାରି ବ୍ଲିଡ୍ କରିବ ସେତିକି ଯାହା ଅଛି ସେ and this is ପକା ପାଣି ପକା
Is 60 or 70, sir, Vicryl?
60
60, okay.
Angelo, soft stick there. See, it stopped.
Yeah, yeah,
But
we can
there
see.
is नहीं ना 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 दे well tight.
Yes, sir. Surgery nicely done, sir. Thank you.
Thank
Congratulations.
you. Thank you very much.
Yes, sir. Really enjoyed the surgery. Thank you to all team
Thank you very
also,
much.
your
Thank
assistants,
you.
everyone. Yes, sir.
ଚାଲୁ ମା ଏଇଟା ବାବା ଅନଲକ୍ କଲୁ ତେଣୁ ମୋଷ୍ଟ ଅଫ୍ ଦିନ ସୁଇଚ୍ ଦରକାର ନାହିଁ ପକାଏ ନାହିଁ
So let us have a big clapping for the surgeon. Yes, from here.
Thank you very much. संगमित्रा कहीं संगमित्रा कहीं अच्छा चल अब किन दे बोल ना बहुत दिन पर यही उठे ही करा होता हमें विश टू डू हियर ओनली यही उठे करा होता इठी पुनः मॉड्यूलर हो गला खाली चेंज हो गला मॉड्यूलर हो गला सुंदर देखा होती हां कर दे
Yeah.
ଭଲ ହେଇଛି ବଢିଆ ହେଇଛି ଏଠି ସେଠି ବ୍ଲକ୍ ଦିଆ ହଉଥିଲା ଅନୁରାଗକୁ ମୁଁ କହିଲି ଘରେ ବ୍ଲକ୍ ଦେ ଗୋଟେ କେସ୍ଟାକୁ ଏଠି ବ୍ଲକ୍ ଦେଇଥିଲା ଡିଟାଚମେଣ୍ଟଟା ତାକୁ ପୁରା ପରଫରେସନ୍ କରିଦେଇଥିଲା ଗଲା ବେଳକୁ ଆସିଲା ବାହାରକୁ ଭିତରକୁ ଆସିଲା ପରେ ଖାଲି ହାଇଟ୍ ନା ମୁଁ କହିଲି ହଠାତ୍ ତ ସବୁ ଦେଖିଥିଲି ମୋ ରେଟିନାଟା କୁଆଡ଼ୁ ହେଇଗଲା ଏମିତି ସାର୍ ତାପରେ ତାକୁ
So as we can see, there is a nice chit chat between G.N. Rao sir and Sangamitra madam. Probably sir is recollecting his old days when he was operating. And as we know, he was one of the initial persons to start retina in our state, yeah, in JPM. And this is always again not a matter of discussion only in our state, outside state also. Sir understands what I mean to say. So his mentors also always mention this and appreciate this.
Camera put re.
Yes, sir.
Okay. Thank you. Thank you, thank you.
Thank you, sir.
अरे तू यार तो इस जो ये तू आनी फुटप्रिंट फटाफट तोर से काम तेईस ପାଇଁ जायस्टा इज इनएफेक्टिव सही थरे ही तमर लैकिंग रोच प्रोफेशनल
Can we change the mic to Sangamitra madam?
तो आशीष करिया तो फुटप्रिंट नहीं जाने
So as we are getting the system ready, may I request Sangamitra madam to please tell about the patient that she is going to operate on. The assistant, please fix the mic over there with madam.
So Chitta, can you hear me?
Yes, ma'am. Yes, we can hear you.
So my patient is a 66-year-old male
Yeah.
who has defective vision for the past 10-15 days.
Okay.
He's pseudophakic for the past 20 years and had undergone laser probably again 18 years back.
Okay.
So there is and a hole just adjoining to the lasered lattice that he had undergone.
Okay.
So I plan to do, ideally with this sort of a detachment I would, and a superior one, I would do a buckle, but probably I will not do a buckle in this case, I will do a buckle vitrectomy. So, yeah.
So only one break, madam?
No, there is one HST and one in the break adjoining the lattice.
Okay. Any pre-op diagram is there?
They are
Yeah,
in
yeah.
half.
Yeah, little posterior, little posterior. Anuja, you can help us in showing the diagram, the chart, if it is there. No, something else came. No, no. Okay. Okay, we got it. So macula is off. Superiorly there is HST and there is a lattice at 1, 2, 3 o'clock probably. Okay, the other eye also is barraged, no? Okay. Okay. Thank you, thank you. Done. Hegala, tolgu nahi jao. File. You are going to put 42 or 240 band, madam?
240.
And suture or scleral tunnel?
No, I'll do suture.
Okay.
That would be a lengthy process, so you guys can get in a cup of coffee or tea and have it without sleeping over there.
Okay. We know you are a fast surgeon, you will finish it fast. So, no problem.
So, our cut rate है क्या कौन अच्छी? Cut rate ये वाला कहाँ थे? You're giving us a 27 gauge? 27 gauge? 25. 27. Okay. Mm-hmm. चलो चलो उठा उठा हट के नहीं जा सकता काढ़ा काढ़ा $42 banded cancer. 42 band. ओके तर नाही की 8वी अच्छा
Anuja, can you help with that?
Okay, I'll just see. This is up, down. This is fine focus. Okay.
Sir, madam's voice is very clear. Your voice is little low volume.
So I'm starting with the case. I will do a 360-degree peritomy.
Sangamitra? So
yes.
Yeah.
I'm doing a 360-degree peritomy.
Yeah.
I don't cut the conjunctiva flush with the white line, so I keep a bit of a conjunctiva so that the closing becomes easier.
And
I
also
do,
preserving some
one-
limbal stem cells also are preserved by this.
Yes.
Yes.
Yeah. So the effect of dryness post-surgery is not much.
Yeah.
While you are cutting the conjunctiva, one should try to put the scissors underneath and clear the tenons as much as you can. So now I'm going to bridle the muscles. These are the tenons. I try to separate them.
Madam, just an addition at this point, probably in younger patients, the tenons might be little tenacious, so we need to kind of dissect them before doing this.
Probably, yeah.
Yeah.
It's much thicker
Yeah.
and more attached to the muscles, so
Yeah.
you need to clear them even more.
Yeah.
So when you're doing these, catching hold of these muscles, you will see there will be an eye opening somewhere. You try to catch hold of that, and then your the threads can come out much easily. Otherwise, you'll go on searching out for where to take out your muscle hook.
Yeah.
Glue on to. Yes, sir.
Yeah, I think Dr. Kanogo, I see here Basically, it's a pseudophakic patient with a superior retinal detachment
Yes, sir.
and a lattice with a horseshoe tear in a superior quadrant. Okay.
And
So,
one attached to the lattice that has been lasered.
okay, okay, that's great. So the reason why we should or we should not do the buckle in such case, do you think it would suffice with simple doing a vitreous
Yes, sir.
surgery?
That is what I told at the beginning. Had it not been a live surgery, I would have gone in for a buckle.
Why does it influence your life surgery?
Because I can't show people probably.
Okay, you want to serve. Yeah, so ideally, friends, in such cases where you have a superior break, now most of the vitreoretinal surgeons do primary vitreous surgery without doing an encircling band, except for cases which are having an inferior break and an inferior PVR, which is unlikely to where you, or in a young patient, child, you might put an encircling band where vitreous separation becomes slightly difficult. In this is a classic case where we can definitely consider a primary vitreous surgery with a superior break with a just vitrectomy, doing a gas and an endo laser should suffice.
Oh, so you were asking about encartilage bandage. I thought primary SBSRFD, buckling with a drainage.
No, ma'am. Sir is asking buccal vitrectomy versus vitrectomy. Why not a vitrectomy only? Why buccal vitrectomy?
Yeah, you can go for a vitrectomy. But when I saw this case, actually, I don't know when I go inside what will be like. There was the lattice that was there. It was not looking very good. So I thought if I give an encartilage bandage, probably it will be better for the future. Like not much of a redetachment. I won't have much of a redetachment chances.
As we have Dr. Prasant Bhabankule over there, sir. One question to you, sir. Dr. Prasant, sir. Can you hear me? Chitranjan here. Prasant, sir, is there nearby?
He can hear you and he is asking you to go ahead.
Okay. So my question is, you have a good publication where you have shown that extensive ILM peeling increases the chances of reattachment, one publication. So in this case, just a hypothetical question, are you planning to do ILM peeling like not only limited to the macular area, peripapillary and all? I hope he got my question.
Yeah, I got your question.
Yeah.
Regarding a publication about which I have published about 10 years back, where we believe that healing of internal limiting membrane just close to macula and also in the peripapillary region
Yes,
gives
sir.
better anatomical success rate in detachment cases. And the concept was what we hypothesized why we had a better success rate compared to other series was that an ILM field releases a tangential fraction which happens similar to what is a macular hole. One thing. Second thing is it leads to complete, it ensures the complete removal of vitreous. Many times if you are trying to fill an ILM, you might be very pleasantly surprised.
Yeah.
Yeah. 1 minute, sir. They are working on the microphone.
Could you hear what he said?
Yes. I had also if you can concise that also, it will be little better. If you can repeat.
So the microphone, we are trying to settle down with the microphone. Probably after that he can speak. Yeah. Let's go there. You should be very important to put viscoelastic over the cornea because by the time you're doing it, probably the cornea will be gone. Yeah. So one should take care of properly putting visco over the cornea so that that doesn't get damaged because the further surgery when you're going to do a vitrectomy, you won't be able to see clearly if the cornea is damaged. Again, then you have to okay.
As we can do, madam is doing the scleropexy with 5-0 non-observable suture over there, and here the role of the assistant is really very crucial because
correct.
Yeah. And also if you have a pulse oximeter to see the heart rate of the patient, because we are manipulating with the
Yes.
muscles. We have Dr. Sweta as the moderator. She is a pediatric and strabismologist. She will also agree with that, because manipulating the muscles, we should always see the heart rate.
Yeah. Hello.
So when you're putting the bites, you should be careful not to go too deep. Otherwise, you'll cause that will cause a perforation, and then the whole surgery goes. I mean, the globe becomes very soft, and then you putting on sutures becomes very difficult.
Agree. Prasant sir wants to say something.
Yeah, can you hear me now?
Yes,
Better?
sir. Yes, sir. Loud and clear. Please tell.
So our discussion was left incomplete because the mic stopped working.
Yes, sir.
See, ILM peeling peripapillary region ensures the complete vitreous separation, first thing, and second, it whatever amount of tangential traction which exists,
Yes, sir.
that is also taken care, and probably that was why we thought we had a better success rate when we do a peripapillary ILM peel.
Okay.
And that was the hypothesis, because one needs to understand PVR is a constant process.
Yeah.
It's not an isolated PVR where a macular hole has a tangential traction while detachment will not have that component. So this is how we thought it loud, and we decided to do it, and we could prove it. It was like that.
Yes, sir.
Dr. Kanugo, why don't you try to be a sutureless by using a tunnel there, a
Tunnel,
scleral pocket, and then a vascular sleeve?
Yeah, I'm quite comfortable with this, sir. I have been learning with this, so probably.
Yeah. Okay.
I am more comfortable, and I think I'm also equally faster as you do it with the tunnel.
No, it's not about the fast. It's about the reason why people have moved is one has to be fashionable like Chitranjan there. Second thing is any suture, any foreign body into the conjunctival sac can lead to exposure and infection. So that is the other way of looking at it.
Yes,
why we
yes.
have to be.
Sir, what
But
is
I'm taught,
what
probably
is
I'm comfortable with this.
exactly what madam told? Two things. I am comfortable and I am taught in that way. So the second part is more important, I think, because like madam is also shares the same alumnus Arvind Eye Hospital, where I think suture was more commonly used. That is the reason. Otherwise, we can go ahead with this tunnel thing also. But as you told rightly, suturing puts a foreign body kind of thing over there. But again, people, those who use the tunnel, like those who argument against that is that you don't get that buckle effect as you put a suture, like 1 mm if you take from both the ends, you get a buckle height kind of effect over there. So yes, there are arguments plus and minus for both the techniques.
No, very true. The height I don't think can be a debatable issue. Because height is basically, it's a reduction of the circumferential diameter of a globe, which is achieved by the how much is the pull on it. Okay.
Yeah.
So I don't see that the suture does compromise to giving any form of height to the encircling, in the case of encircling band, unlike a scleral buckle. Okay. And the height is totally dependent on the how much you pull and decrease the thing. Yeah, we also started, when we started our career way back in 93, we were all suture people.
Yeah.
But yeah, definitely that concept appealed to me, and that's why I moved away from it, and I try to avoid this, nothing more. But it's whatever the surgeon's comfort finally is important. And
Yes, sir.
second thing is you have to be sellable in today's world. What say, Kanogo?
Yeah. Ma'am, as you can see, the ports are little kind of superior, like it's not a obtuse like angle, it's more of acute angle. So for the beginners, can you tell that whether you should have made it little towards the horizontal recti muscle, nearer to that, or little superior?
Chitta,
Yes, sir.
I think it depends upon the surgeon
Okay.
where he or she is comfortable.
Okay.
So I also do little closer to like not
Superior?
exact 10 and 2 as we have been taught.
Okay.
My ports are little towards between 1 and 2 and 11 and 10.
Okay. No, but any changes in your plan if it is a little superior break and while doing laser, any comfort if we have made the ports little horizontal? Just asking.
Yeah, I can take that question. Basically, why for 4 o'clock hours apart the ports of active ports, that is a endo illuminator port and a active port has to go. The reason is in event if it is a lesser inferior breaks where you are trying to do an endo laser, it's always comfortable. But if for a superior break, you have to be having that gives you better access. But for the expertise of Dr. Kanogo and you know,
Santosh bhai,
people
yes,
can
I know
definitely
that, sir. That's why I asked for the for the sake of beginners if they can tell
yeah.
something.
So for the beginners or the postgraduates and the fellows who are watching these surgeries, try to be more than 4 o'clock hours. In fact, when I am doing a surgery, whenever I am looking at a smaller globe, hypermetropic eye, where I do not have much of an orbit to manipulate and a space to manipulate, there I am as away from each other. The ports are almost 3 and 6 o'clock, 3 and 9 o'clock.
Okay.
Okay. So smaller globes, tighter orbits, you should move away from more than 4 o'clock hours. So here we have a wide angle weaving system in the form of boss. What is it? Recite by size.
So here is the break that you can see. It is at the edge of the lattice. And there was one superior break over here.
Yeah.
The reason why I gave an encephalage band was the whole eye is filled with so many lattices in the inferior part also. And to do a complete vitrectomy in these lattices is very difficult because once you try to pull out the vitreous, it leads to a retinal, it gives rise to a hole. So while you are going near the lattice, your cut rate your suction should be very low, such that you can go near the lattice and you can trim it. The vitreous can be trimmed. So first, as usual, you do a core vitrectomy. My cut rate is 20,000. I'm doing with a 25 gauge cutter with a bottle height of 35.
As we can see, the surgeon is nicely doing the core vitrectomy, almost completing the core vitrectomy in a very short span of time.
That's the beauty of a 20,000 cutter actually.
No, also credit goes to the surgeon. It's not only the cutter.
The tricot.
PVD was complete, madam, or?
I'm putting the tricot. Let's see. The
Okay.
PVD was there, but still for the sake of rechecking it again, I'm putting the tricot. रिफ्लक्स काम को नहीं रिफ्लक्स कहाँ पे ये पीछे वाला है ना where is the reflux ये वाला Where is? Oh, kitchen name, huh? Oh. So this is a very unique technique with the constellation. You can take it and do the reflux over here. and then you can see don't need to go with your syringe. I think there is complete PVD there. There is no vitreous attached. No, there is no vitreous attachment. So I can do the base dissection now. Indent karo. So while doing the base dissection, if you are going very close to the retina which is attached, it's okay. But if it's a detached retina, probably your suction again should be very low.
How much is the vacuum now, ma'am? Maximum vacuum? The vacuum is now 200?
Vacuum is 400.
400, okay.
I think the external camera can go on the screen.
Next.
Yeah.
वो जो कैमरा है टीवी उसके ऊपर लगाओ. किधर है स्क्रीन?
कहाँ पे?
And you don't use PFCL now? You don't need it?
No, not PFCL now. It's the superior break, actually, it's not hindering. So
Okay.
as long as it's not hindering me, probably I will not.
Okay.
हो नहीं? Quarter? So if you're not very sure, you can pull the vitreous by using your vacuum. See, you know, there's no vitreous over here. Next. Yeah, I can. Yeah.
So again, for the sake of all the audience, indentation and base dissection is a very crucial step in the management of retinal detachment surgery by vitrectomy, and the role of the assistant nurse is very crucial in this. So I think she is doing a very
Yeah, as you can see, there are a lot of lattices over here. I'm going and trimming around those. I'm not trying to induce pull the vitreous at that point, because
Yes.
that will inadvertently give rise to holes and detachments.
Yes.
Go near the buccal, go near the lattices.
That also justified your putting a band that because
Yes,
multiple.
that is what.
Yeah.
So the vacuum is very low now, 150, 160. I'm working very close to the retina without pulling it.
Okay.
I can just go to the sides of the lattices and just can trim it all around.
Okay.
Next. इसको पका पानी आपने.
And ma'am, the tip of the cutter is like the 10,000 cutter, that port optimization, what they did, the port towards the end of the cutter. Is it like the same of 10,000 cutter, this 20,000 cutter?
Huh?
Yeah, exactly.
Yeah. It's exactly the same.
Okay.
તમારે ये ठीक से ये करने इंडेंट करने तो लंबा करने इंडेंट कर. बहुत लंबा करे ना पूरा ऑप्टिक नर्व हेड पड़े बहुत पछू पड़े
So one thing we can compare for the sake of cataract surgeons, just like the subincial cortex is little more challenging to take out, similarly what madam is doing now, just below the dominant hand, whatever vitreous is there, doing the indentation is little more difficult over there. But as we can see, she is doing very nicely over there also. The indentation is also very good.
next indentation any indentation 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 is very very crucial.
True.
So this is where the retina is detached. So while working near the detached retina, one should be again even be more careful. Otherwise, it's very fluttery and will come and catch on your cutter tip. Indentation ये करा ठीक से करा नहीं सब ठीक से करा but मैं ये करना stable रहूँ next hello yes. This is where again one more break is there. I'm not trying to pull over here because there are too many lattices over here.
Yeah.
You can see.
Yeah, bhai, we can see. Santosh, can you tell what exact vacuum madam was working over there, like 150 vacuum, na?
Yes, 150 was the vacuum.
Yeah, correct. You can see very stable and no fluttering of the retina.
And this is the detached area.
Yeah, correct.
It is below her hands. So it's almost 12 o'clock she is operating. At 12 o'clock. As the break is superior and we have superior RD, I think we can use gas in this case.
Yes, I think I'll use gas only.
Okay.
Now the vitreous is very clearly seen there.
Yes.
All the vitreous need to be trimmed off, which are attached to the break and surrounding lattice area, which is the most crucial step. And that determines whether post-operatively we have a attached or detached retina after the gas is absorbed. All the traction need to
for
be.
beginners, I would say one should be very, very, you should have a lot of patience in doing a retinal detachment surgery. It cannot happen that quickly.
Yes.
Because if you are very fast and you leave off all your vitreous, then definitely the patient is going to come back with a bad PVR.
Yes.
For us, I think number of breaks,
next.
size of breaks, or other things doesn't matter. The most important thing which matters to us is the vitreous. So you need to take out and trim all the vitreous.
Correct.
So that you will have less chance of PVR. You may have two small little breaks while removing the vitreous, but you can afford it and the retina remains attached after you laser it out or cryo it out. But all the vitreous need to be taken out. That is the crucial thing for a detachment surgery.
So what Santosh Bhai is saying, very important point, we should get rid of all the vitreous. That's why this indentation and base saving are very crucial over here, because the remaining vitreous leads to PVR and again recurrent detachment.
This is the vitreous that is there.
Yeah.
So at the cost of 1 or 2 small breaks, if it happens while trying to trim all the vitreous, that is also okay, but it is not good to leave any vitreous. That's the important message I want to give all the
Audience. So yes, bhai, message well taken, point well taken.
Okay, done.
Now she has almost completed the vitrectomy in the periphery.
Yes.
Yeah, here you see there is some amount of vitreous here.
Yeah.
This is the lattice that is here, surrounding the lattice. The vitreous is very adherent around the lattice.
Yes.
So one should be very careful while doing it. This is a detached retina also. Indent out के जगह कल्ला. से ए पटे जगह पछूटी जाएगी ना.
So it has been done very nicely, and the beauty is that she has not used PFCL. So again, it's very good. But for the beginners, maybe using a PFCL will be a little better. It will act as a third hand of the surgeon.
Point here, Chitta, is don't put PFCL without doing a PVD.
Yeah, correct.
So do a PVD if it is not there. If it is there, try to separate the vitreous beyond the mid periphery.
Then
put PFCL over the posterior pole.
Correct.
And you can trim the rest of the vitreous after that only.
Correct.
So it is always necessary to separate the posterior vitreous before putting PFCL.
Yes.
Otherwise, it is very, it increases the chance of like PFCL going behind if there is a traction and a hole nearby. As well as it will be difficult to separate the posterior vitreous after putting the PFCL over it.
Yes, correct.
So you can see the fluttering of the retina where there is vitreous.
Yes.
There is a big hole over here.
Yes.
The retina flutters. If you go near it, if there is vitreous, the retina flutters over there and tries to get into the mouth of the cutter.
Okay.
So almost everything is done. I will do a fluid exchange and then do a laser.
Are you going to do diathermy to mark the holes? Because
yeah, that is a good idea actually.
Yes, ma'am.
So diathermy.
But see, only one break?
No, there are 3 breaks.
3 breaks. 3 breaks and all are primary, no iatrogenic break.
So diathermy is done? Okay.
Till now, no iatrogenic.
No iatrogenic break.
Where is that HST? Oh, this is HST. This is HST. So when you're doing a diathermy, if there is vitreous, you can see there's the vitreous they come towards the diathermy port, and you can know that there's some amount of vitreous there.
Yeah.
So that is another one way of knowing how. No, there's no more over here. Okay. I'll do a fluid exchange.
And madam, you are planning
now you have to do the tightening of the buccal.
Yeah.
And
correct.
then a fluid exchange is done.
And laser only to the brakes, or additionally 360 barrage you are planning to do?
No, we can do laser to the brakes. Actually, there are so many lattices there. a good idea would be to cover all those lattices also.
Okay.
It is better to do a 360 degree, particularly in this kind of cases, where you have multiple breaks as well as lattice in other areas.
Yes.
Light को
And
ऐसे
the other
कम-
option is also you
light
can
को
do
इतना कम आ रहा
cryo
है।
to the primary breaks which are larger.
Okay.
I do cryo many a times.
Mhm.
Just sufficient, not more, not less.
Okay.
Because more cryo will attract PVR
Hmm.
and less will leave the margins, may leave the margins uncryoed.
दियो, आउटर दियो।
So you have to
नहीं, तो
titrate
पूरा ये
exactly
है,
how much
पूरा बाहर
cryo you can do. Do you do cryo, Chitta?
No, very less. My choice is towards laser only. Cryo very less.
Now you are in the era of vitreoretinal surgery. We from scleral buckle days, I am fond of doing
That's
cryo.
why you are having expertise of both the worlds, both buccal and vitrectomy. We are little moving towards vitrectomy. But as you can see, one recent publication was there again from like when I was in
Yes,
Arvind.
yes.
300 cases of
Yes,
buccal
that
cases.
we have gone through.
Yeah.
That is good that people are now coming back to buckle.
Yes. That's why we have captioned it as 300 cases of buccal in the era of MIVS.
Yes. Very nice article. I have gone through it.
Yes. Thank you.
So the infusion port is coming out again and again. I'll do it in a different place. There.
Okay.
Dara. Why is the light so less? Eta go. Out pre. Epada. Eta. Why is it so small?
So again, just as for the cataract surgeons, the bottle height is very crucial. The like bottle becoming empty becomes a nightmare. Similarly, infusion is very crucial for the VR surgeon. As you can see, if it is loose, we have to fix it fast before going to the next step of the surgery. Yeah, if it goes subretinal or suprachoroidal, it's a cause. Shashwat is telling this.
Yes, it is a nightmare actually.
Yeah.
So again, you have to recheck it, whether it's there or not, and then switch it on.
Yes. Again, a smart assistant again helps in this case. The surgeon may be concentrating on the best decision over there. So assistant also plays a very crucial role.
Dara.
Yeah.
Yeah, I would have said.
She is now going to tighten the band. It is a good idea to tighten it before. I usually do it towards the end, whether it is oil or gas, because that also titrates how much you can titrate either way.
Yeah.
Either you can tighten it before and then decide how much air or gas you want to give, or you can wait till you almost fill the eye with air or gas and then tighten as much as necessary.
So अब स्टिक करना ये करो.
He has kept it little loose knowingly, so that the final titration after injecting the gas can be done and the amount of gas can be decided for the final intraocular pressure.
What gas you are planning there, Santosh bhai? C3F8 or SFC? C3F8?
C3F8.
Okay.
Little longer staying gas.
Okay.
You do SF6?
I do SF6 by, and that too a different, it's a venting technique, like we inject 2 cc of 100% SF6 with the infusion open. So there are...
I do C3F8 with that technique only. The eye is filled with air and then finally...
Okay.
2 cc or 0.2 cc?
No, 2 cc. 2 cc, I inject 100%. So again, the argument against that is that probably it may not be that 14% or 18%, whatever we intend to, but there are publications, because again, as madam told rightly, whatever we are trained with, we continue that. And all my SF6 are, be it macular hole or RD closing with gas, I use 2 cc of 100% SF6, but like C3F8 18% or 14%, that can also be used like before injecting, we calculate it and we inject it in that big series. That is also there. What you are going to there in the theater now, Santosh bhai? C3F8?
She is going to C3F8.
No.
It's coming down actually. Your microscope is coming down.
Now you can adjust the table accordingly. Huh? Up or down.
So as you can see, very small but important discussion over there. If we are having difficulty with the microscope, we can adjust the table height. This is a very smart work of smart way of working over there.
Go for fluid exchange now. See, fluid exchange can be done with the cutter, can done with the flute. Depends how much control you have over each instrument. As because we are doing now 25 gauge, it is always better to do with cutter, because that saves times as well as you have control over it. And it is, yeah. And one thing to remember, it has to be done under direct supervision, under direct visualization.
Yes.
Your
Float.
cutter tips should be visualized so that you don't catch the retina inadvertently.
Yes.
এটা কোন ইয়ে কোন এটা সফট টেপ হ্যাঁ সফট টেপ
Maybe you may not complete the fluid exchange with the cutter. You can do the last part of the exchange with the flute. That is always safe.
Yes, while going near the break, to use a flute is much safer.
Now, as you can see, all the subretinal fluid is now coming down.
Yes.
Retina is settling.
So as we can see over here, the surgeon is removing the fluid from the retinotomy portion first. Even though there are fluid in the posterior pole, we should not be tempted to remove that. Otherwise, the fluid again will travel subretinal and will be collected in the posterior pole. So the point is that we have to drain it from the hole first.
Correct.
Yes.
So it presses the fluid over the posterior pole, actually presses the subretinal fluid.
Yes.
No.
Conta? So there's a lot of fluid over here, yeah?
Okay.
You want to do a retinotomy there?
No. I'd rather put a PFCL rather than doing a retinotomy. PFCL there.
Sangamitra, you have done the air fluid exchange, right?
I have done an air fluid exchange, but sir, as you can see over here, there is some amount of fluid that is there in the posterior pole.
You stay Tell me.
Yeah. So I think I can't leave this fluid as such, because again, it might open up the break if I'm giving gas. And the patient is not taking a proper head down position. So I can put PFCL at this point and take out that fluid that is there in the posterior pole. And be safer actually.
If all the
your opinion, sir?
Open breaks are open, if you can
Yes.
close all the brakes, even if you leave the fluid, nothing will happen. But one
Right.
important thing I want to tell is that when you are going for air fluid exchange itself, instead of aspirating the fluid in the vitreous cavity, you only stick to the brake so that all the subretinal fluid will come out. Then the fluid, if you, which is there in the vitreous cavity, you aspirate last. Then there will not be any subretinal fluid left. So no need for using PFCL at that time. In this case, if you don't want to go for, otherwise you can re-exchange and drain out all the fluid as you like it. As you feel comfortable,
think
because this is
I
more
think I'll
live.
put PFCL at this point and then drain it off.
Yeah, ठीक है, वो कर लो, देखते हैं. We will see another technique, right?
Oh, obviously.
Yeah, no. Sangamitra, whatever you feel comfortable, please do it, because this is live and it should go. Yeah. You are the best judge. Yes.
So while you're putting the PFCL, one should look at the pulsation of the optic nerve head.
Yeah. And it's already getting
You
pale.
should not overfill it.
Now, one thing is that you should stay within the bubble so that it will maintain the single bubble. Otherwise, if you are staying away from the PFCL and injecting,
Yes, that will
multiple
create,
bubbles
lot
will
of
come,
bubbles over there.
and there is a risk of small bubble going subretinal. अभी तो आ रहा है ना? Now it is coming, no? Yeah.
Now I think the posterior pole is completely
Yes.
settled.
Yes.
Removal of PFCL can be done now.
Yeah. First, let her complete the laser, no? That will be better. After that, she can comfortably remove the PFCL.
Yes, sir.
Laser.
Yeah.
Okay, laser.
Okay. Laser.
Ida, power, laser power, बढ़ा. Interval कौन इतने नहीं.
Interval 200, 250.
250. Duration सेती रहो. Interval टा कमा. Hello. On.
Ready.
Where is the foot switch?
Ready, press कर.
Okay.
Yes, nicely. Laser is coming now.
Very good. Very good laser.
That is another test that all the
Very
fluids
nice.
are drained.
Yeah.
Can you hear me, Chitta?
Yeah. Chitto, I sent him for lunch. I am there.
Oh,
Okay.
sir. Okay.
So no problem.
Good that you are.
That's why I'm
good that you are there.
I'm speaking. I'm sorry, but I
No,
thought
no,
they
it's
should
good
have the
that you
lunch.
are here,
Yes.
sir.
Yeah.
We are.
Actually, we should do the tight laser. Means spot to spot.
Yes, I'll
there
do
should
it.
not be any gap. And certain times what I do is I dithermize whichever breaks I am seeing edge, so that I will not miss any break while doing the laser.
There is some amount of fluid over here.
Doesn't matter. If mild fluid is there, nothing to worry. That will
Yeah.
disappear by first day.
Laser ଟା ବି ହଉନି ହଁ 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 ଖାଲି ମୁଁ କରିଦେଉଛି ଛାଡ଼ି ଦେଉଛି ଓକେ ହଁ ଦିଅ ଇଏ ଦେ ଫ୍ଲୁଇଡ୍ ଦିଅ ହଳଦିଆ ଲାଲି ଲାଇଟ୍ କ'ଣ ଆସିନା ଯାତ୍ରା ହେଉଛି କି
Sir, what is your suggestion? The laser around the brakes or 360 degree?
I do around the brakes. Around the brakes only, yes, yes. You should be clear that, good afternoon. You should be comfortable, you should screen all the 360 degree, but do the laser only around the brakes. That would be suffice.
Okay. Because we have put a belt buckle, as almost no need to do 360
The peripheral
degree.
traction is anyhow taken care.
Yeah.
So I'll remove the fluid,
PFCL, yes.
The PFCL, and then go in for the.
The retina is looking perfect. It is very well settled.
Yes, yes.
Now, I think we can.
Yeah, you
give
can
the gap.
straight away aspirate the PFCL, because actually for the audience, PFCL aspiration comes out very smoothly without any difficulty. While removing the PFCL, you see for the last bubble, so that you can ensure that 100% of the PFCL has been aspirated.
Yeah, gas.
Yeah. Which gas are you using?
C3F8, sir.
C3F8, yes. See, there are two gases which are at our disposal. One is SF6 and other is C3F8, which means SF6 will be lasting only for one or 1.5 weeks, max 2 weeks, and C3F8 3 to 4 weeks. So it depends on our comfortability. We can choose which gas we can exchange. This is I'm telling the audience so that they will. I think this is the last case.
No, sir. We have one
more
case with Dr. Babankule will operate, and
okay.
I have an injection, just PFS, Rajuma PFS.
Okay.
Last case will cancel in interest of the time. Because we are
ठीक
late.
है. Okay.
I have to operate that
You can
case
start
because
your
we
this thing.
promised,
Where
but
are you
will
starting?
Not live.
Oh, Santosh.
Sir.
Actually, there is a workshop. Plastic workshop is there. Whether they are planning in Hall A, can they do it?
As they can do it in halls B or C.
C,
As
acha. Okay.
later.
Yeah. That's
Because
what they
we have
wanted.
a session at which is later.
Yeah.
Hall B or Hall C, wherever they like. Hall B will continue with this.
Okay.
Please convey the message, sir.
Yes. They already.
The globe is soft, so I'm going to inject some PFCL. Line put kara
What is this you are injecting? Acha, little bit hypotony.
I'm injecting some amount of C3F8.
Yeah.
Close
Hypotony, because of the hypotony.
Yes.
Close the ports.
Yes. Close. Switcher there.
80. then inject acid. ସବୁ post
ଏ ଗୋଟିଏ ତମର ଇଏ ନାହିଁ ଦିଅ
Yeah, since the conjunctiva is not there, gas is leaking actually. We have,
Yes.
if conjunctiva is there, it would have stopped once it is in good pressure equilibration.
okay you don't have this thing no Santosh glue nahi glue dara it is leaking over here.
Sangamitra, you can close the conjunctiva first. Close the conjunctiva, no problem. Little bit hypotony should not be a problem. Close the conjunctiva. After that, transconjunctival she can inject. See, gas is leaking now because the conjunctival coverage is not there. Tenons and conjunctival coverage is not there.
Then connect आराम microscope connect
क्लीन करा Yeah. लाइन से क्लीन करा फोटो
हाँ उसका प्रेशर ज्यादा है
हाँ तो
देखो प्रेशर 200/150 हाँ वो है मैकुलर होल ले लेते हैं नहीं मैकुलर होल ठीक अच्छे आ गोटे डायबिटिक केस
That is what happens. ଯେତେବେଳେ ତମେ ପୁରା ତରବର ହବ ନା એટલે ବେଶୀ ଆହୁରି ତମର ଇଏ ହବ।
वो रिजर्व में एक होल भी रखा था कोई भी एक रखेंगे ना उसका ब्लड प्रेशर 200/100
ଏପଟକୁ ଆସିଲେ
कौन सा करना मैकुलर होल कर जो तू बोले बाकी बाद में जो मुझे खत्म करना पड़ेगा କେତେ ହେଲା ବ୍ଲଡ୍ ପ୍ରେସର କୁମାର ପଚାରିଲେ
କୁଆଡେ କ'ଣ ଗଲାଣି ମୁଁ କିଛି ବୁଝା ପଡୁନି।
କହିଲେ ବ୍ଲଡ୍ ପ୍ରେସର କଣ୍ଟ୍ରୋଲ କରି ଆସିବ ଇଏର ସବୁ ଠିକ୍ ଅଛି ଯୋଉଟା ଡିସାଇଡ୍ କରି ଯୋଉ ଡାକ୍ତର ଯାକ ମତେ ପଚାରୁଛୁ କ'ଣ ମୁଁ ଦେଖିଛି ତମ ସାଙ୍ଗେ କଥାବାର୍ତ୍ତା ଯେକୌଣସି ଇଞ୍ଜେକ୍ସନ୍ ପେସେଣ୍ଟ ଡାକିଦିଅ ଯେକୌଣସି We are almost completing this case. We'll take the next case as intravitreal PFS Rajumab. Are you able to hear me?
ଯେ ଆଉ ସୁଚର ସୁଚର ପଳେଇଲା ଯେତିକି ତମେ ତରବର ହବ ନା ସେତିକି ତମର ଇଏ ହବ।
Hello. Am I audible?
କେହି ନଥିବେ ଆଉ ସେଠି ଖାଇବା
Yes, we can hear you.
Yeah, this case is going to complete. Next case will be a intravitreal Rajuma PFS. And then we have a macular hole which will be operated by Dr. Prashant Babankule.
Okay, ଆଉ ଟିକେ ଦେଇଦେବା। I'll just inject a little more and then leave it. Stroker over there.
You can speak.
ଟିକେ ଦେଖିବ ପ୍ରେସରଟା। ଚଲ ମୁଣ୍ଡଟା ଟିକେ ତଳକୁ କରିକିନା ଶୋଇବେ ହଁ। Slapstick, slapstick. iPad. चल हाँ ये वाला निकालना है ना।
Recording stopped.
श्वेता, संतोष सर बोल रहा हूँ। हेलो, कहाँ पे हो तुम? हॉल पे कोई है कि नहीं है? कोई सुनाई कि कोई ने कुछ नहीं बोल रहा है?
We are waiting for your surgery, next surgery.
कोई नहीं है उधर और कोई ऑडियो हमारा सुन नहीं रहा है।
We are in the hall. We are waiting for your surgery.
Rutindu, can you hear us?
We can hear you loud and clear.
They can hear.
We are waiting for your next case actually.
No, actually we have been talking since last 5 minutes, but nobody is responding from your end.
No, I think there was some transmission issue. And we are also feeling sleepy. I think you need to start your next case.
Okay, Dr. Santos is going to give Rajuma PFS injection to Rutupurna Patnaik, 47-year female, who
আপটা আছে আচ্ছা এটা কি আরাটা ডায়াবেটিক মাকুলার এডিমা ডায়াবেটিস হুম
So she has moderate NPDR with CSME. So he's going to inject Rajumab. He's going to demonstrate how the pre-filled syringe is and how he is going to give it.
Co-cover. सीधा करा तू क्या करे कथा कर
When they're draping and cleaning, you show the PFS syringe,
Hmm.
how it is used.
PFS कहीं तो सिरा छाड़ा और PFS कहीं PFS कहीं PFS कहीं PFS कहीं PFS कहीं PFS कहीं PFS कहीं
Recording in progress.
PFS कहीं हाँ कौनटा এটা সারা PFS कहीं हाँ हाँ সেটা আনে হও এটাকে গঞ্জি দেন তো PFS টা দেখে সারা মূর্খটা শুনে প্রিপারেশনটা দেখা আরটা দেই দেবা কোন আছে So the PFS, as we are discussing, has advantage of saving time as well as cutting the chance of infection because of less handling. It is a pre-filled series with ranibizumab, and you just need to take out the needle and attach it with a 30 gauge needle to make it ready for injection. I think we can demonstrate you how it is being done as the patient is getting ready for injection. Towel पके सर की दिखेगी घर पर दे दे ଆପଣ ଆପଣ କରୁନାହାନ୍ତି you are on steroid I'll ask Dr. Sangamitra to show the full then how to take it out and after that we can take it come here भूल जाते shadow भूल जाते shadow सेठी कैमरा আছে
So this is the pre-filled syringe, and you have a 30 gauge needle over here. So I have to give him the pre-filled syringe. Oh, sorry. Okay. So this is the pre-filled syringe of Rajmab that is there, and with the 30 gauge needle that comes with the packet. So what you have to do, I have to give this pre-filled syringe to him, and he'll just take out this plunger from here and attach the 30 gauge needle to it.
এটা এটা attach হচ্ছে
It attaches to microscope.
this microscope can I have the microscope camera on microscope camera on yes now this is the pre-filled syringe you have to take out sorry you have to just remove the cap after breaking the seal and then is it seen there you have to just open it then take out the cap just ask whether it is visible or not
Can you see that?
Yes, yes, visible.
Yeah, yeah.
And
And
this
then
way
you attach the 30 gauge needle to it.
make it air free as usual keep as much as you need 0.5 पहली बार देखा है you can keep as much as you need just like 0.5 ml for intravitreal injection
The amount that is there is 0.165 ml in the needle.
The marking, can you show a little closer, the marking one?
closer to the microscope or
No, 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 no. Closer to the patient, maybe away from the microscope, so that it will be clear.
yes, yes. Yeah, that's it. Is it visible now?
Yes, little more centered, please. Yes. Okay.
now he'll make it 0.05 and then inject.
Kadicha.
Yeah, got it.
Do you want to reposition the speculum for the upper eyelid?
Yes.
Full.
धर এটা দেখা যায়নি মাইক্রোস্কোপটা আগেও দে ফিক্স করে দিয়েছি এটা দেখা যায় না Can you see now, Chitta?
Yes, bhai. We can see this mark is 0.05 ml.
Yes.
Okay.
Right.
Okay. Okay. We can see
Now,
clearly.
0.25, we have discarded the extra amount.
Okay.
And kept it 0.05 ml.
Okay. Okay.
This is a pseudophakic eye.
Okay.
I'm taking 3.5.
Okay. Can you please recenter the cornea to the center, please? Little inferior. Able to move little inferior. Or microscope up superior. Yeah. Yeah. Good. Good. Correct. Yes.
ମାଟିକେ ବାଁ ପଟକୁ ଉପରକୁ ଅନା ମୁଣ୍ଡ ହଲା ନାହିଁ ଏପଟକୁ ଅନା ମୋର ତମର ବାଁ ପଟକୁ ଅନା ହଁ I usually ask the patient to move the eye because it is under topical.
Yes.
And I inject inferior temporally. See how the patient is being positioned. So it is easy, and the caliber is both taking the measurement as well as fixing the eye.
Okay. Correct.
The other hand, you can directly enter.
Yes.
And the direction should always be towards the center of the
globe,
vitreous cavity.
Yes. So.
And I keep the cotton tip applicator right near the injection site, so that there is less chance of oozing out of the drug, as well as hemorrhage. Subconjunctival hemorrhage can be also prevented.
Yes. Very nicely given injection, and for the audience, as Santosh bhai told, the pointing should be towards the center of the vitreous cavity or center of the globe. Why it is important? Because the patient tends to move the eyeball. So we should point it towards the center of the globe, and it should be perpendicular to the scleral surface, whatever injection we are giving.
So the PFS helps us
4 mm.
The step of extracting the injection from the needle after pricking the vial is avoided, and you can just take out the shield and adjust the volume and inject directly.
What may be the complications?
It is almost now approved for most of the indications of Rajumab except ROP.
Okay.
So everybody can start using Rajumab PFS.
So what Santosh bhai is saying is very vital, because there are publications which say that when we inject the needle through the, even if it is a sterile vial, when we pierce the rubber cap, the lubricating things or the rubber things, whatever is there, sometimes that may cause some sterile inflammation. So this PFS syringe, it obviates those steps.
I got injection as well. Sauna gopan to macular hole bisare. Janto gopan. Upon share polantu. Light. Keep the light on. No. I am talking of that light. Huh? Okay. बंद कर
दीदी एबे कार अछि मैकुलर होल जो जंतु पेशेंट केस दियो
पेशेंट ब्लॉक दे
केस ये फाइल केस फाइल हां केस फाइल वो ला रहे हैं सर उधर वृंदावन में पति मैकुलर होल केस है मैडम भाव
Like counter.
इसे अपना ऑडियो दीजिए खाना खाई दे एठी हमरा अछि कैंटीन
एठी तब कहि दबो कैंटीन को कर का बड़ कह
ओ कोन खाई दे
Hello, Bhutendu, can you hear us?
Yes, ma'am. Yes. Chitranjan here,
So
but we can hear. Yes.
So the next case is going to be operated by Dr. Babankule. So this is a 68-year-old male, both eyes pseudophobia, visual acuity of 6/8, 60 in the left eye. The left eye has got a macular hole. To operate on this patient. He's going to operate on the inguinity that is they're setting it up. So probably that is why it is taking some time.
हाँ इधर कर ले कोई भी चलता है यार जो है देख लिया तूने देखने के बाद मेरे को देखने की आवश्यकता नहीं है कोई एंटी सेगमेंट वाले ने देखा होता तो मुझे देखना पड़ता
So this ingenuity is a 3D viewing system wherein you don't have to see through the microscope. You can look at the screen which gives you a magnified image and then you can operate on it. While he is operating, probably you'll be
close
seeing
6.5
in your screen also.
I need powderless it's in my room they have my boy has got हाँ नहीं 6.5 मेरा लड़का ने लाया है उधर है वहां अंदर हाँ वो लड़का नहीं कहीं से इधर से घुस जाते ना टेबल के वहां अप्रोच हो जाएगा रेडी एक्सक्यूज मी चलो क्लीन करो अरे आया नहीं पेशेंट
Yes. Yes. Okay, so this is the preoperative OCT that you are showing, right? Is it
माइक्रोस्कोप कौन है
This is of the left eye.
ये
The
अप एंड
OCT
डाउन
left eye.
okay?
ये फोकस है
Is it a senile macular hole or any history of trauma or anything is there?
No history of
और
trauma.
ये
It's a
magnification?
senile macular hole.
Okay.
Okay, fine, fine. That's fine. Clean karo, karo.
Yes.
Yeah.
So by the time they are fixing it over there, for the sake of our audience, the surgeon is going to operate on the Ingenuity system. As you can see, there is one additional glass is given. That is a 3D glass for him, because it is a 3D system, so he has to see with the 3D glass on. And the steps of macular hole surgery we all know: corbitectomy, PVD induction, trichot assisted maybe, then dye assisted ILM peeling, and tamponade with a gas. So we have a great surgeon with us, Dr. Prashant Babankule sir. He needs no introduction. So we are going to see the surgery now. I hope the system is getting on. Also, you know that in Ingenuity we have different color filters also. Sir, are you going to use the color filters also there?
Are you going to use any filters for doing the macular?
Yeah, I would try to show you how the it enhances your visualization.
Yes, sir.
Routinely, I don't need to if I am using a dye, but in extreme situations where there is a where there is a severe choroidal sclerosis, like in a high myope, or a posterior staphylomatous, where the contrast is not there of the retinal pigment epithelium, there we definitely need the we have to use rather the filters to enhance the visibility of a internal limiting membrane in spite of staining.
Yes. And sir, how many pair of glasses do you have over there, 3D glasses?
So here, just for the sake of, probably I have not seen the patient clear, means at this point of time, how much is the sclerosis, but I personally
No. I am asking for Sangamitra madam and
we will
Santosh.
definitely show you.
3D glasses.
Yeah, everyone would have to use, whoever are visualizing on the screen.
Yes, sir.
Unfortunately, the transmission to your center at the place in the conference is not in 3D. So they would not appreciate the thing in the 3D. I would be seeing, and the people in the theater.
Okay.
While the image which is coming to the audience over there in the hall is going to be 2D.
Okay.
So we have put on a 3D glass.
Yeah, it's a Polaroid glasses.
Polaroid glass.
Basic.
Sir, about the staining. About the staining, have you ever used this ICG staining?
Very early in my career, we used to use ICG dye, but it is known to cause phototoxicity, and then we had an option of, a brilliant blue, which stains ILM as well. So since then, I have given up, and now I don't need to. And now with the Ingenuity with us since last 5 years, ICG dye I have never used rather.
And additionally, sir, if it is a phakic eye, maybe poster capsule will be more stained with the ICG. So BBG is having advantage over there. But yes, ICG have a better advantage. It stains a little better than the BBG, but it comes up with the price of these things.
Now they are talking about using it in a more diluted form. Recently, in certain selected cases, some of the centers have started reusing it. I don't remember, Divansh, I'm saying. Chitranjan, do you remember the latest concentration which you were talking about, non-toxic dose?
The ICG?
Yeah, ICG, now they are talking about using a diluted version, and that is supposed to be non-toxic.
Okay, no sir, I'll find it out, sir. I'll find it, put in the group.
Okay, no issue.
Yes.
No issue.
And in all sorts of macular hole, you do an inverted flap, sir, or there are just in peel off in very small macular holes without doing an inverted flap?
Yeah, the literature per se says that anything holes which are small, what are small holes are less than 400 microns. So if the 400 microns, frankly speaking, the literature says that you do not need to stuff the or do an inverted flap. You just have to release the tangential traction by doing a sufficient ILM peel. Nowadays, the newer advocate is about only doing a temporal half of it and releasing the temporal traction, and that should suffice. That's what people say about. So I think this dimension, I don't remember, have we done the dimension of this particular hole? But for the sake of demonstration here, I would try to do an inverted flap. That looks more attractive to the common ophthalmologist and the audience which we are having today. Usually, I don't have to, really, frankly speaking, unless a RP is very unhealthy, it's a long-standing hole, and then only we are for sure going to do inverted flap. In a routine case, flap of hole size less than 400, 500, I can do a conventional ILMP, not an inverted flap.
And what about the tamponade, sir? Do you give air in some of your cases?
Yeah, any hole which is less than 400 microns, RP is healthy, air tamponade. It is the first 24 hours to 36 hours where the tamponade has a role, they say. Or in event if it fails, then we can think about re-injecting later.
Do you do a fluid exchange over the hole or just leave it as such?
No, I see if I'm doing an inverted flap, I do it under PFCL, I do the stuffing part of it. Regarding the, so that I don't lose upon the flap. Now regarding doing fluid air exchange and trying to drain the SARD which is present associated with the macular hole, I don't think there is any necessity to drain it. Unless it's a very high myopia, posterior staphylomatous eye where the fluid is more proteinaceous in nature, which takes months to dissolve. In such cases, probably you have to do a very controlled type of a drainage with 42 gauge type of a needle.
Yeah, the chances of touching the edges
RP.
of the hole and the RP also is there. So that is why we usually avoid that.
Correct. Ready? Are we ready?
So as we can see, the three surgeons, they are discussing about making the retina or the macular hole very dry for a better success of the surgery. At the same time, we should take care not to injure the
Help
RP.
me with the chair. OT ka phone hai bachcha
So
lo.
now patient is ready and sir is getting ready to operate.
ऐसे रखना है. This is sterile. Saline मार. Caesar दे.
So now we are going to watch a 3D movie.
Yes.
Caesar दे. Caesar दे. Caesar दे ना इकडचे. Caesar दे म्हणत आहे. Wash. Kuchi. So, am I getting some objection? I'm not getting.
I hope the image is clear even in 2D.
Yes, yes, it is clear even in 2D, but we know that Sangamitra madam and Santosh bhai over there, they will be having a 3D because of they are having the Polaroid glass. But the picture is very clear, sir.
Yeah.
So whenever you are using an Ingenuity, the basic thing is how do you start? You have to move to the highest magnification, and with that, whatever conjunctival surface is available, you have to focus on that, and then you have to zoom out. So that's what precisely I did. Wash.
Yes.
Wash, Kuchi. Kuchi.
Kuchi मैंने cotton board दिया sister.
So now this is the Johnson bud which we use. I will be displacing the conjunctiva so that my conjunctival opening does not, match with the scleral opening. And so that is why I push, and then I go obliquely, and this is my 25 gauge which I have put a trocar over there. So this is my first, through which the infusion or the irrigation aspiration fluid will be going inside the eye constantly. Okay, then I need to first confirm it. Endo illuminator, please. One needs to always confirm that the infusion cannula is intravitreal and not into the subretinal. You can see the shining over there.
Yes,
That's
yes,
what
I can see.
I have confirmed it. So this is the first step. Once we have an infusion cannula in which is going into the vitreous cavity, my job is done. So I prevent. And now the second is
I prefer to place, unlike Dr. Kanugo, and place my two active ports, that is the superotemporal, superior ports, about being a pseudophakic about 3 millimeter behind the limbus. You have the option here, which are like a caliper. This is the other end of the trocar, which gives it. So the first marking is 3 and the other marking is 4. So somewhere 3 millimeter we can do. If it is a pseudophakic patient, the fear of hitting the natural crystalline lens is not there. Yeah, can I have an endoilluminator now? And so now I'm using a constellation system where I'm going to use the 25 gauge cutter. This is at 20,000 cuts per minute. The vacuum is at 500 cuts per minute. Okay, 500 vacuum. Okay, and this is 20,000 cuts. So this is the now vitreoretinal surgery, like anterior segment surgeon, like your phaco surgery, has become really a predictable surgery and a fast surgery. With 20,000 cuts, it makes your life VR surgery very, very fast. So this patient is pseudophakic. There is a posterior capsular deficiency, as you can see, in a retroillumination. So first is doing a core vitrectomy. I'm trying to do anterior vitrectomy and then core vitrectomy. Now I will move to the wide angle viewing system, which will allow visualization of the posterior segment. Can I have this biome or whatever it is? Reside, please. ऊपर लो हाँ ठीक थोड़ा थोड़ा उधर हाँ बस okay fine done. Can you focus it for me? Focus वाला कहाँ है? Focus अजून that's it. Can I have some saline on the corneal surface? So here you see an optic nerve head, a disc which is quite pink, and this is the macular hole which you can see. I will just show you under high magnification. This is the thing.
Yes, we can see.
Okay.
With this 3D system, even the vitreous is so clear.
Yeah, vitreous is clear, the field of view is better, the depth is more better. In fact, if you are seeing on the screen, right now I am seeing on the screen with the glasses, I am not peeping into the eyepieces. Unlike the previous surgeon who were using the microscope analog system, they were looking into the eyepieces like any one of us, all the ophthalmic surgeons do. This is the difference. So it's here I'm looking at the screen like a laparoscopic surgeon and operating, not looking into the eyepiece because the people have removed the eyepieces here.
Yeah.
It takes care of your back also.
Yes.
Neck and back.
Yeah, that is a concern for aging people. For people like me who are still into teenage, it's not a concern and I don't look at it as an advantage at this point of time of my age.
No, sir, for ergonomics of the surgeon is very vital, be it what kind of surgeon. So for this, I think Engineer's advantage for this ergonomics, better ergonomics is number one. Apart from this, anything you want to enumerate, sir, Prasant sir, regarding ingenuity in vis-a-vis the conventional other systems for VR surgery?
So after that, as already said by Chitranjan, the first step in any VR surgery except ROP surgery is induction of PVD. I'm going to use the active vitreous suction of a vitreous cutter and I'm trying to see whether there is any vitreous which is not yet detached. Fortunately for me, what I perceive at this point of time is that it's all PVD was present, so that's a good sign. Yes. So I don't have to much delve into it. And here again, in such a macular procedures, we are not really bothered about removing the last bit of peripheral vitreous.
Yes.
You have to take care predominantly of the posterior pole, but at the same time, do not be in such a hurry that you leave a large skirt of vitreous which can lead to reproliferation of the, because more the vitreous you leave in the periphery is going to act like a cell bank.
Yeah.
From where the cells will migrate and move into the vitreous and can cause reproliferation on the posterior surface. Can I have dye?
Also during the vitreous PVD induction, as we can see, the surgeon was doing it along the blood vessels, along the arcade. This is for the sake of the residents and fellows who are sitting over here. We should not just blindly do the PVD induction. We should do it along the arcade.
unlike Dr. Kanogo, here I'm using simple syringe to pump the dye. You can stain the internal limiting membrane under air. People recommend that, as well as you can do it directly under the fluid. Under air, you get a better
You get a very
contrast
better
and a
star,
more
yes. Then you
stronger
just-
strain. But well, most of the times you can see sufficiently enough even under the fluid. And I'm a slightly lazy person compared to my previous VR surgeons. So I look at what is fast. Probably, but for a fellows or the fellows who are watching or the PGs who would like to, they should go in a what is copybook style. As you mature in your, can I have some saline on the cornea? It's not giving me wave.
Also, sir, some people do partial FAE, half filled with gas and half with saline, and then they do BBG staining.
So you can see I have adequately stained and the ILM is stained. You can see as a blue contrast against the RP.
Yes, we
So
can.
this is a relatively easy thing in this particular case. Here is a CRA or a lattice which is radial along the vessel, which will need a laser. Usually in a macular hole surgery, we don't do lasers. But if you have some predisposing lesions like this, I might prefer to do a no, it needs more focusing now. Can I have focus?
Focusing.
Focus तिथून कर बेटा. नहीं, उल्टा.
Ulta.
That's it.
Correct, correct.
That's it. So now you can see the difference in the focusing here. The
Yes.
environment being slightly new to me. And yes, so I thought of going ahead. So I have stained the internal limiting membrane now, and now my job is to peel the internal limiting membrane. I will request Dr. Kanogo to take over till I get the edge of the ILM. Focus, बेटा, थोड़ा सा focus कर. Yeah. So you can do it under high magnification. Okay, I start usually temporally.
So you don't use a scraper to scrape out a bit of a
Yeah.
ILM over here?
No, I prefer, I
Pick
still
and-
do pinch and peel.
Pinch and pick.
So pinch and peel technique is being done over here, as we can see. Some people use a Finis loop also.
Definitely it's surgeon's choice.
Yes.
Yes.
Whether you can get a flap, initial flap with a forceps or a.
Can I have some water on this thing? Corneal water.
Cornea.
And for demonstrating, I will be using a filter. Can I have an ILM filter? Filter.
ILM filter.
Alcon. Filter. Color filter.
Which color?
Yellow. So see, you can see the difference in the visualization now. This is how the filters in this digital system allows you a better view of it.
Yes.
The cornea is getting dried actually.
Yeah, and हाँ डालो एक बार सलाइन डालो.
Yeah, he got
Yeah,
a
so
edge to
first
it.
age I got it now.
Yeah.
Can I have a hand support here?
Hand support is there.
हाँ ठीक है, thank you.
As we can see, sir has nicely taken out the first pinch, that edge of the flap. Now he is working on the edge of the ILM flap. Yes, now it is just like making a rexis kind of thing. But he will be doing the ILM flap also, like the inverse ILM kind of thing. This is the color change in the filter, I think they have done.
Yeah.
Wow, very nicely he's taking it up.
Yes.
सलाइन मारो थोड़ा सा बस
So there are different types of ILM peeling. You can pull it in toto like a CCC, as Dr. Chitta was saying. You can do it like a flower petal and put it over the macular hole.
relief of a traction is most important.
Correct.
Tangential.
So, for the sake of audience, like we all know that ILM is the thinnest part, probably some 4 micron or 5 micron, where the surgeon is working. We must know what amount of dexterity and hand-eye coordination is needed for that, and what complications may happen, retina touch or some blood, like blood vessel injury or something, as we can see. So nicely being done surgery, there is no retinal touch, no bleeding, nothing. And because we want to preserve a piece of ILM over there around the hole to be tucked, that's why we are taking care not to remove in toto. The staining has been very good over here. Contrast is very beautiful.
It's a very slightly thin membrane.
Yeah. So thin and parchment kind of membranes, they come in pieces. They don't come in toto. So again, that adds to the difficulty of the surgery.
Saline.
Do you do from arcade to arcade peeling?
No, I don't think there is any necessity of it. The thing is, see, if you are using an inverted flap, nowadays they are talking only about removing the half of it and putting back to it. So relief of tangential traction is predominantly this part. So I'm almost completed. I was just wondering loud. I'm wondering loud for all of you, should I do a complete 360 degree or not? So
Actually, you can do only the temporal half.
yeah, so that is a modified technique which now people are in a smaller holes. In a larger holes, yes, we do complete because we would like not to fail. But now with smaller holes, this is also, even this temporal relief is sufficient enough, and I would stuff them into here. So Filmsy, very filmsy. This is where basically, unlike ILMs, sometimes when I see, look at the OCT, I knew this was a very filmsy membrane. So here, otherwise, that ILM is like a capsule only. It works as easily as that. Yeah. So this is, when we see, look at it, its configuration was almost a lamellar hole, which is converted to a full thickness macular hole. So this is a degenerative type of a lamellar hole where the membranes are very ill defined.
Yes.
Okay. So in these cases, you do not get that option of, having a nice feel of it and taka finishing off. Okay.
That's why it is just
Saline.
it-
It's a
after each
degenerative
bite,
membrane, yeah.
It is coming in very small fragments.
No, basically I'm not trying to peel off the entered part because I want to use this flap too. I can peel off the used part. So if you are trying to preserve this, I'm trying to go intentionally away from the area which is, so that it doesn't come out into my forceps. That is the reason. Otherwise, if I if I use this edge, I can peel off
You
rapidly.
can take the rest of the eye.
Exactly.
That's another point, very important point, that you need to preserve some ILM for such holes which have a chance to fail in the primary surgery.
So point is very well taken. If you want to preserve a piece of island over there, then we have to be very careful. Otherwise, taking out in toto will be probably little easier. But as the surgeon wants to preserve ILM to tuck it over there, because that will work as a scaffold over which the layer will form, the retinal layers, and it prevents the
So
failure
now
of the
I'm
surgery.
using a PFCL bubble under which I will be stuffing. Sorry, it happened into multiple bubbles, fish shaking, but I will force it into it. So I use now a PFCL bubble. Here the PFCL, unlike in a detachment, is used for different reason. In a detachment, you use to steamroll the fluid out of it. While here, I'm using the heavy weight which acts like a mercury. So that this flap is not lost. What I'm trying to do when I'm going to invert this flap into this hole. So my job of peeling about more than 180 degree I have peeled off. Now my job is to stuff this membrane into the hole. If I try to do it under the fluid or under the air, it comes into my suction device and I can have a lost flap. So this is what is called lost flap. This is very not uncommon in a degenerative type of a ERMs.
Prashant sir, any thought of staining it under PFCL? That means PFCL putting first, then staining, then doing ILM peeling. Any thoughts on that?
It is better to do what is easy because staining doesn't happen that adequately then.
Okay. So as we can see nicely.
As I said, degenerative membranes are most difficult to peel as well as see. Okay.
Okay.
So as long as possible, do what is conventional.
As we can see, the flap is very nicely tucked in the hole over there. There is absolutely no trauma or injury, no RP injury, no retinal injury.
So just to sum up now, most of the job is done. I have peeled off the membrane on the temporal side. What should be the size of the peel is when I'm doing inverted is it should be twice the size of the hole. So if this is the size of the hole, I have gone 2 times beyond it. From there I started peeling. So temporal, and this is the part which I have peeled off, and this part I have left over in case if I need in future as well. It is now believed that even 180 degree peel on a temporal side is sufficient enough in an inverted flap technique in a smaller hole with a healthy RP. So this is it. Once that job is done, now my job becomes to just see the periphery, remove peripheral skirt of the vitreous, whatever is there, to reduce it to the minimum and then do a fluid air exchange. So,
sir, what is your opinion regarding in partial ILM peeling, like peeling a donut-shaped ILM or doing a hemitemporal ILM peeling?
Pardon, I didn't get your question.
No, that is your other thing. No? So actually, there are some other peeling techniques, where they spare the ILM over the papillomacular bundle, or they do a donut-shaped peeling. so that they leave some ILM around the fovea so that the molar plates, they are not disturbed, and that leads to good visual acuity. So you have any experience about that?
So I will just show you last time, because once I start an fluid air exchange, you can see very well the blue ILM over there. This is a bare area which is devoid of ILM, which you can see as pink, while the ILM which is preserved, means left over, is this side. And on the nasal side, as you can see, this is a ILM which I have preserved. So I have done only ILM peel, and this blue is the flaps of the ILM which I pulled from this region, which I have stubbed into this hole. This will help in growing. Can I have a laser as well? This is probably a lattice which is what I should say, radial lattice. I would just do a prophylactic laser for the sake of safety. Laser. So I don't know whether you can see us from there, the outside video. I request them to give us the feed of how we are operating, looking at the screen and not into the thing. Can it be shown? It's showing, no? 200.
It can
Duration
be shown,
100.
sir. It can be shown. Like you want us to see the panoramic view.
Continues. Done. So this is continuous way of delivering the laser, which I do sometimes when I am lazy enough. So this is a barrage which is being done. So this is prophylactic barrage laser which I have done. Can I be off the filters, both digital as well as laser filter? Alcon people. Can you remove the filters? Laser filter. Yeah, so this is the prophylactic barrage laser I have done to the presumed lattice, which is radial and along the vessel. And now I will do a fluid air exchange, and that almost ends the surgery. Can I have fluid air exchange? And now look at the field of view, unlike the previous things where you can see as much up to the equator in a single view. Okay, this is the advantage of these digital systems. Fluid air exchange, fax. 40. Thick. On. So now my job is to remove the fluid which is ahead of the PFCL bubble, and then remove the PFCL without losing the flap which is embedded into the. हो गया? Fax चालू हो गया? हाँ? मला कटर दे. Just to enhance the speed of FG in a 25 gauge, I sometimes use an active mode of vitreous cutter to help me in draining the fluid more rapidly. These are some things you learn as you age, and with 25 gauge it is almost very controlled, and you can see rapid removal of this. Smaller the ports, this drainage and all can take a longer time. And now because we are used to more faster surgeries, our threshold for waiting and doing it passive effusion, draining the fluid comes down. There, flute. Saline. So here now I am draining the fluid in the vitreous cavity first up to the edge of the PFCL bubble. I will like to retain the PFCL bubble till the last, till I have removed the fluid. Why? Because the moment that fluid is removed, that bubble is removed, that flap which is stuffed into the hole can float out. And it, because of the current of the fluid movement, it sometimes just gets sucked into your passive effusion, even into the flute needle. So in a flute needle, this is a passive way of draining the fluid. And in spite of that, because of the height of the bottle or the predestined internal pressure of IOP, it can suck into this IOP. IOP pressure is 40, fine, no issues. So now I am removing the last part of the PF cell bubble. Saline. ले लो. That's thick. And you look at the field of the view, which in spite of such a magnification, which you can appreciate with the 3D digitally assisted systems, you have fantastic view. And this is why it is now a preferred way of how I operate in all the cases. Even my cataract surgeries in one of my theaters is only on digital systems. It enhances your visualization by giving adequate combination, a unique combination of a magnification along with depth of field of view as well as great depth. Otherwise, in an analog microscope, the moment you increase the magnification, the depth as well as the field of view comes down, unlike in this digital system. Okay?
Sir,
so
in
that's
the
why
very,
you can see the whole picture in toto.
Sir, in the very initial period, there was certain time lag for the anterior segment surgery, but I think that was taken care of by the system, by the company people.
There is, but probably my brain reflexes are slow, so I never felt that. In throughout my, it's more than 5 years I've been using it. I have been a slow surgeon probably, or my
No.
brain
I
reflexes are
remember you presenting combined
talk
surgery,
about
sir.
it.
Cataract and VR surgery,
There
sir.
are surgeons who talk about it and do not use it for anti-segment surgery. But if you see my videos, I have been doing any anti-segment work, even my iris repairs, which I saw showcased you in the morning,
Yes, sir.
is all done on systems.
Okay.
So even the most complicated cases we do in this system rather than on an analog microscope because it gives you a better viewing.
You can see how he has put his tip only on the optic nerve head. It's not going towards the macular hole site at all.
Yeah, because
That
the otherwise that and there is no need to drain a subretinal fluid even if it is there minimum. Luckily in this case there was no SRD. Yeah. The hole was almost like a type 2 closure type of a hole without much fluid cuff.
Would you like to give a SF6?
Yeah, in this case we will give. Okay.
So as we can see, the last
Even
bit
if
of
we
the
don't give,
PFCL
it's
is
just a matter of debate now. Saline. Bas. So you can see it now, wonderful view. You have a disc optic nerve head here. You can see a macula stripped of the ILM in this area, which is pinkish. And this blue area is in the center is the stuffed ILM over there. So this is all that is macular hole surgery on a routine case, routine day. If this is would not have been a degenerative type of an ILM, I would have finished in 15 minutes. But this is a new setup. So, and the newer system, so it takes time. But otherwise, we as a VR surgeons are now competing with all the phaco surgeons in the duration of a surgery. And in fact, we can do as fast as you, as a phaco you can do. So that's the end of the surgery. Now I just have to put a gas and close the thing.
Yes.
Can I remove this? Can biome?
Very good surgery, sir. Surgery खूप छान है.
बाजूला कर. हे. हाँ. Reverse anti-segment view. Anti-segment view. हाँ. Inverted. That's it. Can I have a better view? Full view. ये रेट्रो में किसने रखा है? रेट्रो व्यू में रखा है बेटा आप लोगों ने, इसलिए इसमें दिख नहीं रहा है. देखो ये यहाँ से ये जो रहता है ना, ये बढ़ाओ ना. हाँ बढ़ा. नहीं बेटा वो नहीं. हाँ करेक्ट. You had kept in retro and that's why initial view was not that good. अच्छा. So now this are the ports which have to be removed. We can have it as a sutureless 25 gauge, just you have to massage. Because my conjunctival entry and the scleral entry were not overlapping, you can see that here is the black and the conjunctiva over here. Differently. That is how you should place through it, by sliding the conjunctiva a bit away. And here you can see now a port Now just I have to slide the conjunctiva, but here I think the conjunctiva has got torn. So just I will slide the adjacent conjunctiva, or you can use a atovicryl here just to put a suture if you are afraid of losing. Yeah, I would prefer to put a suture here, atovicryl, because here the gas has to remain. Otherwise the leak will lead to hypotony, and the use of expansile gas will be it will just leak off, and so we will have a hypotony, and that closure before that it will happen. छोटा वाला needle holder नहीं आणला बेटा हाँ मग हे का बरं तुला अरे यार इट्स दे छोटा वाला needle holder नहीं है का दे needle holder अजून एक needle holder काय झालं बेटा विसरला का एक अजून सूचर आहे Yeah, that is also leaking. I will put a feature out there as well. Tooth.
It's still. Okay. Time change. I don't know what is the time now.
So this is the view, as Dr. Prasant was saying. You can see he's not peeping through the eyepiece of the microscope. That means it's not needed at all. He's looking directly at the screen, and he's operating over there like a robotic surgery or a laparoscopic, what you can say.
आपले मेटल होल्डर सांगितले मी है ना अजून एकदा ते क्या एक लीक हो रहा है थोड़ा सा that's still continuing to leak not getting
So you should always scrutinize all these leaking areas and don't do misery in putting a suture.
yeah
Otherwise, post-operatively there'll be
Wash.
like a. नहीं, इस नहीं.
Needle holder. Yeah, as very rightly said, minimally invasive vitreous surgery is about not about making it sutureless. It's about.
The sutures are.
I am not happy with the suture. Yeah, next suture there. Yeah, give me. So it is not about. It is through going through the minimal space. So we are going. This is 25 gauge, means almost 0.3 millimeter is the size of the 3 ports. So, and especially when you are using a gas or an oil, you need not be miserly about using a atovicryl, because sometimes the gas can leak or an oil can leak subconjunctival, that can give rise to more longer, bigger a problem. Okay, so it is better now here, because I am needing a gas. That's what I have taken a call for putting a gas in this particular case. I would prefer that it is leak proof.
Cornea. Not side, Now I think it's done.
Yeah, I think the last port is done. 8 Kuchi. दे दोनों दे लगा देते हैं अभी लगाए हैं तो अभी unnecessary. This is transconjunctival transcleral suture. Subconj.
The surgery is over now.
Yeah, I have to just put a gas and I give subconjunctival injection which you use in a cataract surgery as well, something like this.
As we can see, the surgery is done very fantastically. So all of us, let us very big hand for Dr. Prasant Bhavangule. All of us over here.
Puli Kuchi. So here I am injecting a C3
Please,
effect,
yeah, C3F8,
0.4 ml.
0.4 ml.
Yeah.
Yeah.
Chalo.
Undilated 0.4 ml.
Yes. That's it. अच्छा हो गया. So thank you everyone for watching the surgery, and thank you Dr. Chitranjan for moderating from there, and my colleagues over here, Dr. Kanogo.
Thank you sir. बहुत अच्छा हो गया sir. खूब छान है. बहुत अच्छा हो गया.
Thank you. Thank you. खोल देना थोड़ा. चलो बढ़िया हो गया. Thank you everyone. ये पीछे से.
So one announcement over here, as we have come to the end of the live surgery session, this all we will have the GBM at 4 o'clock, 4 p.m. तब तक के लिए let's have our own personal times. चाय मिलेगा सर फ्री? हाँ? 4 p.m. 4 p.m.
Excuse me. Hello? On करून दो.
Even that thing also will get.
Hello? Yeah, we will have GB at 4 p.m. at Hall B. Everyone can go to Hall B.
सुनाई दे रहा है पीछे? Please come, please come. We are already late. They are calling from the GBM. Please come. Come, come, whoever have done, please come. Dr. Anuradha and Dr. Mona Lisa team, please come to the stage. We are already late now. Otherwise, our General Secretary sir will put a complaint in the group then. वो लोग भी actually they have changed the time for this, है ना? They have changed it to 4:30. असं असं. Secretary. झाड़ू नहीं. असं असं समजते असं. Those who are not coming will be So please be seated for 2 more minutes. We'll just be felicitating our faculties of the workshop. So I call upon Dr. Mona Lisa Patnaik. Please, Dr. Anuradha can give the memento to her. So this is just the beginning of oculoplasty in Odisha. I want more and more residents to take up oculoplasty as your specialty. We'll just alternate. So with smiling faces. So, ଆଉ ଗୋଟେ ଆଣିଦିଅ ନା ନୀଳାଦ୍ରି ମୁଁ ତାକୁ ଦେଇ ଦଉଛି ତୁ ଏଠି କହିଦେ
So now we are feliciting Dr. Anuradha. She is practicing in Kara Clinic. Sorry, Kara Clinic.
So now Dr. Mona Lisa will felicitate Dr. Bigya Birajita Panda Madam. Thank you Bigya Didi for starting this oculoplasty session. I hope from all of you somebody will take oculoplasty fellowship in future. Yeah, they should. With the aesthetic thing, they should.
Yes. So thank you all for attending this workshop. We'll hope for a advanced workshop in the next year. Okay, thank you so much.